Ma'am, we are in live now.
So just 1 minute. Yeah. A very good evening to one and all of you here, and truly a delight to see the cream of expert panel and the best of speakers here. We wanted to work out on a kind of webinar which would be all encompassing the different spectrum of ophthalmology. And then we thought of this myopia panorama update, which seems to be a very hot topic at this present time. And with the array of topics, I'm sure it's going to be a webinar really worthwhile to watch. So thank you, one and all of you. We have on the expert panel, Dr. Rohit Saxena. I'm sure all of us know him so well as a professor and heading the pediatric establishment services at RP Center. We have with us is Dr. Jitendra Jethani, who's again a pediatric ophthalmologist and squint specialist from the Baroda Children's Eye Care and Squint Clinic. We are very lucky to have with us Dr. Shreya Shah, who's the director of the Drashti Netralaya and also a pediatric and an oculoplasty surgeon. And the interesting thing is, which really is amazing, is she's also a faculty of the art of living. So I think maybe just being in a company would pass on those, that feeling of goodness in us too. Sadly, we don't have Dr. Professor Subhash Dadia joining in because he's caught up with some academic work. And we are all familiar that he's a professor of ophthalmology and leading the Guru Nanak Eye Center, and is also the president of the Pediatric Ophthalmic Society of India. We have with us Dr. Bhanumati, who he's the head of the department and consultant of Pediatric Ophthalmology and Strabismus at Narayan Netralaya, Bangalore. Thanks a lot, Dr. Bhanumati, for being with us. And
thanks a lot for inviting me. I think Swati is my student actually, so
yeah,
that's all.
So you have to see how well she performs today. And
Swati is really good. I know her. Her conception of film is superb. So would have known by now.
Dr. Swati, as some of you would be knowing, is a consultant cataract, pediatric, and strabismus services at the Eye Foundation branch based at Coimbatore, and she's going to do a wonderful job of moderating it. Our first speaker, Dr. Ramesh, wanted to join in. There's a second speaker, and I look forward to having Dr. Siddharth Kesarwani, who's again a pediatric ophthalmologist from GNR Children's Eye Care and Squint Clinic based at Thane, Mumbai. And he is going to talk on a very important topic, preventive care, pre-myopia, identification and management. So on to you, Dr. Siddharth. We'll abide by the time, and our office guy, Mr. Vel Murugan, will let you know 1 minute before that, just 1 minute is left. Thank you. On to you. I hope you have audio is on.
I think I saw it's on right now.
Yeah.
So thank you for including me in this panorama, and I've been given a very interesting topic, pre-myopia. And myopia suddenly, as you said, has become a poster child for pediatric ophthalmology, and suddenly everybody wants to know stuff from us. Earlier, nobody used to call us. Now every day we get calls from people asking about myopia and management. So adding to the whole thing is this concept of pre-myopia, wherein let's start with the definition. So the International Myopia Institute defines pre-myopia as refractive state of an eye between plus 0.75 to minus 0.5 in children, where a combination of baseline refraction, age, and other quantifiable risk factors provides a sufficient likelihood for the further future development of myopia to merit preventive interventions. Now, what does it mean? Basically, you are trying to identify myopia before it starts. So here few factors you will consider. What are those factors? What is the age of the patient, and what is the corresponding refractive error at that age? If his parents have myopia or not, if he has got any binocular vision disorder, Does he have sufficient outdoor time? Does he do excessive near work? And what is the magnitude of refractive error at that point in time? And what is his ethnicity? And what is his axial length? So basically, there is a group of factors which predispose a person to myopia. And we want to identify those factors in a child and be on our guards to prevent myopia rather than trying to prevent its progression. So this is a concept which is lately catching up, is whether we can actually prevent the onset of myopia rather than trying to prevent the progression of myopia. So let us see one factor at a time. So the cutoff for predicting myopia by age 13. So how do you know if a child is going to get myopia by the age 13? His age appropriate refractive error is less than what is expected. So usually we expect hypermetropia in children, and as age progresses, hypermetropia decreases. There are certain studies which have followed children over a long period of time and can't come up with the average hyperopic refraction that a child has at every age. So if a child has got less than that hyperopic refraction, then he is probably moving towards myopia. So if the hyperopic refraction is less than plus 0.75 at age 6, if it is less than plus 0.5 at 7 to 8, if it is less than plus 0.25 at 9 to 10, and if it is less than 0, or if it is emmetropic at 11 years, then probably the child is progressing towards myopia. Not necessarily, but he is at a high risk. Now, children who are losing their hyperopia quickly between visits. So if last year you saw the child, he was plus 1, and this year suddenly he has become plus 0.5, and previous to that there was no change, then probably you are looking at the very recent onset of myopia. Now the family history also has to be taken care. You have to ask the family history. If one myopic parent is there, then it increases the risk of myopia by 3 folds, while if 2 myopic parents are there, then that becomes 6 folds. What does it mean? That if for the same refractive error, a child with parents with myopia will be at a higher risk than a child with whose parents don't have myopia. Same with ethnicity, like Asians are at a higher risk of getting myopia versus Africans and Caucasians, and Indians are somewhere in between Asians and Africans. The visual environment of a child also contributes to his risk of getting myopia. If he is spending less time outdoors, then he is more likely to get myopia. And on the contrary, if he is spending more times indoors doing a lot of near work, then he is more likely to get myopia. If he has got any of these binocular vision abnormalities, then he is at a higher risk of myopia. For example, if he has got esophoria or high AC by A ratio, accommodation lag, or intermittent exotropia, this predisposes him to get myopia. Now, once you have diagnosed pre-myopia, then you want to know what to do about it. You know the child is at a risk for getting myopia, but then what do you do about it? Now, the challenges are that you have to communicate to the parent that your child is going to get myopia and you have to do something about it. Many parents will say, right now he doesn't have any problems, so we don't want to do anything. But it's very important to explain them. If the parents have glasses, then it's easier to explain. If parents don't have glasses, little more difficult to explain. And then you have to make a plan. What is the best appropriate line of treatment for them? So what is the plan? So once you diagnose pre-myopia, you ask them to increase outdoor activity for more than 2 hours a day, decrease reading, gadgets, cell phone and tab, replenish the vitamin D if deficient. So many studies have shown that vitamin D deficiency also predisposes to myopia. And reduce the intake of refined carbohydrates, which involves corn flour or maida or sugars. Whether you will start low dose atropine is an open question right now. There was a trial done in 2010 which showed that children who were diagnosed as pre-myopia, when put on atropine, had a lower risk of developing myopia in the subsequent year versus the same group of children who were not given the atropine. Study ongoing, ATOM 3 study is ongoing right now, which is going to check whether 0.01% actually prevents the onset of myopia. The results will be out probably next year. Now, even if you have diagnosed pre-myopia and you want to start low-dose atropine because there is a strong likelihood of the child getting myopia because of a strong family history, the sibling also has it, then you can still start low-dose atropine. But because it is right now not the standard of care, you would probably counsel the patient and take an informed consent and restrict the use to more than 6 years age, not give it to a lesser age group right now. Whether optical treatment has any role? So right now, if the child has got any binocular vision problem like esophoria or high EC by ratio or accommodation lack, then a near vision correcting glasses for near activities may help. Vision therapy can be tried for esophoria or intermittent exotropia. Although these interventions are not proven to be of till date that they will prevent the onset of myopia, but because these are the risk factors, controlling them might postpone the onset of myopia. There is right now no evidence that myopia control glasses or contact lens will help in pre-myopes as of now. So in conclusion, once you diagnose a pre-myope, right now you will probably increase the interval of follow-up. If you can call them every 4 months or 6 months, you can probably catch the myopia early. Increase the outdoor time. The lifestyle modification has to be instituted immediately because increase in outdoor time is known to reduce the onset of myopia. So that is a definitive thing that you have to do. You have to counsel the parents, tell them that the child needs to go out every day. And low dose atropine in delaying myopia onset may soon become the norm because the results will be out soon. But still, you can start giving it to people who are at a very high risk. But please do take an informed consent. Thank you very much.
Thank you very much, Dr. Siddharth. So, yeah. So then, Dr. Rohit, does that mean, as he was trying to convey, that offsprings of myope or siblings of myopic children, you would actually think of starting atropine for them?
So these categorize as high risk factors for development of progressive myopia.
Yeah.
At the moment, as Siddharth has said, there is no evidence that we should treat these children. But these children being at risk, one intervention, which is lifestyle modification, is something we must institute in all. In fact, I everywhere say that childhood myopia is the youngest lifestyle disease that is happening in humans. So just like for a diabetic, we tell them to be off sugar and exercise. For a child who is at risk or a pre-diabetic, a child who's at risk for myopia, we advise them lifestyle changes, and that is the best and the most important intervention. There is adequate evidence that it prevents the development of myopia. Preventing progression is still equivocal as far as evidence goes. So we must advise lifestyle change and highlight the risk factors that these children have and manage modifiable risk factors. At the moment, there is no evidence to say that you should give any other form of intervention, whether pharmacological or optical.
Yes, Swati, you have a question to ask?
Yes, sir. There are a few recent, very recent studies about red light therapy in pre-myopes and early myopes. In India, at our Epics Institute, are we planning anything like this? Are we trying any such things? Controlled red light exposure?
So I have actually gone and tried this device. It's a commercially available device that gives red light. Of course, there are two things to this. One, the controversy, red and blue light, because even the blue light has been shown to have some effect on myopia progression, which is again a very unusual kind of a finding. But most studies have talked about red light. I've gone and actually experienced this light, which can be extremely, I mean, I found it difficult to sit for the 3 minutes and to expect a child to do that for 5 days a week for months at end, I think would be a challenge. Commercially available, we are yet not in the process of trying this out because I still feel that there is more evidence required, especially on how this is working. So we have not tried it. And like I said, I'm still waiting for scientific evidence, either in the form of evidence of effect or a scientific basis before we could actually, we have to develop the device or import the device before we can actually give a realistic evaluation of this study.
Thank you, sir. Because there was also a single case report of decreased ERG waves around the macula following light therapy. So this is something I think that at least until we have better evidence, even one case with such a bad problem, we should not be promoting this device. So this is something that people who Google and come and ask us, we should be having some consensus among us pediatric ophthalmologists. Thank you, sir.
Dr. Shreya, what are your thoughts about myopia progression with chronic inflammation like VKC or allergic eye disease?
Yeah, so that most of the time we think that it is myopia progression, but some of the time you have to look for the corneal changes, which is just happening because of the rubbing of eye, and that you need to look into keratoconus, and that is the earliest sign. You can just look for the keratoconus. So whenever you are feeling that, along with your myopia progression, along with that, if you are seeing any time in topography skewing of fan, so it should alarm your mind, and we should take care immediately as fast as possible. Earliest CCR, C3R or collagen cross-linking may help, but ultimately, Dr. Rohit also said lifestyle modification, particularly in this myopia. And again, we have to stop child. In every pediatric ophthalmology, we have to say that stop rubbing eye. We have to teach their parents also.
Swati, do you have anything else to ask?
No,
Before
ma'am.
we move on? Has Dr. Ramesh joined it? I don't think he has. Then Rohit, you have anything to add, or should we go to the next speaker? Something which is very relevant, which is so important, which is not covered in this?
I mean, I think everything is covered, but what I'll say is for all of us ophthalmologists, lifestyle change is something we cannot, under stress for everybody, including the children. In fact, there are some few things which I tell, like the phone is only for talking. In fact, I encourage parents with progressive myopia to give their children their old Nokia phone that they have discarded or couldn't find anybody to give it to. So phone is only for talking. Do not have any kind of viewing screen less than a tab, and even the tab very rarely. All academic activity, a desktop or a laptop. All entertainment, including playing games or PUBG, on the screen on the smart TV. So these are among the basic lifestyle. A lot of ambient illumination. Your desk should be opposite an open window, a bright window, so that the moment the child looks up from his books or anything, he's looking up far in distance. No reading, no tabs, nothing on the bed. Whatever, even if you're, kind of doing your work and even entertaining yourself, do that on a desk chair, because that's the place where you can actually maintain distances. Lying down, your distances are not controllable. So, I mean, there are a lot of these others. What I'm saying is all of us should compile a list of these and give this to all parents and children, so that this is highlighted, that lifestyle change is just like, so underrated for parents. They feel that this is actually nothing, but really the impact of lifestyle change can be tremendous, and preventing myopia has been proven in multiple studies across. As I said, preventing progression is still equivocal evidence.
Ma'am, shall I just add one point?
Yes.
It is not just only watching the mobile or playing games, even scholastic activities like reading, writing, doing artwork, any kind of near work is going to actually progress your myopia at a faster rate than what normally it would be. So I think we have to emphasize on parents, because they keep sending them for tuitions and they are so much into academic endeavors. So that also has to be emphasized. Even storybook reading, because they say my child is a voracious reader. They gobble one storybook after another. That has an equal impact in myopia progression, similar to what Dr. Rohit says as far as games and other devices are concerned. So we have to emphasize that is also not good. Just make your more than red light or blue light. I think it's the sunlight which is most vital. So just go out and play and spend less than 2 hours apart from your schoolwork. So the maximum amount of study a child during the growing time that can be spent on the desk work is less than 2 hours in a day. So this has to be emphasized. Even scholastic activities will have an equal impact.
Thank you.
Chitra ma'am?
Yes, let's go on to our next speaker. Dr. Ramesh hasn't joined in yet, I think. Dr. Jatinder is there. So Dr. Jatinder is our senior visual retina consultant and uvea consultant at the Eye Foundation group of hospitals based at Coimbatore. He's a right hand, left hand, a truly dynamic, versatile surgeon, and he's going to be talking to us on insight into pathological myopia, exploring the retinal manifestations. So on to you, Dr. Jatinder.
Thank you so much, ma'am. Thank you for this invite. Am I audible? Are the
Yes.
slides visible?
Yes.
So in the CE of pediatric ophthalmologist, I'm just here to give my inputs on the retinal manifestations in pathological myopia. The challenges are numerous. Just to enumerate a few, the risk factors and the underlying pathological processes are still poorly understood in pathological myopia. The progression and atrophy are still untreatable, and a standardized set of definitions and classification is yet not completely agreeable and not available. So we can see this kind of finding in myopia, but this is a patient who did not have myopia. So just to highlight that you can have findings which are very typical of myopic eyes, pathological myopic eyes, which can be seen in a non-myopic eye. And similarly, a finding like CSR can be present in a patient with high myopia. The high myopia definition was typically described as high negative error, somewhere between -6 to -8 diopters with eye elongation, the axial length being 26 to 26.5 millimeters. And pathological myopia was labeled as 28 to 29 millimeters. However, this was disputable. And now what is agreeable is any macular alteration which is induced by high myopia with axial myopia and or posterior staphylomas. Posterior staphylomas is the pathognomonic finding, and we'll discuss that more in detail. The other findings which will be highlighted are the choroidal atrophy, myopic CNVM, myopic tractional maculopathy, dome-shaped macula, and the macular Brook membrane holes. So the pathological myopia, as described by Spade in 2013, is outpoaching of the posterior wall of the eye with a radius of curvature which is less than the surrounding curvature of the wall, as is seen in the figure C. And this has been described well in a very elaborate research article by Curtin in 1977, and this is still being followed. With the advent of newer technology, the wide field fundus imaging, swept source OCT, and the 3D MRI, the understanding of this disease has become easier and is more understood now. So the definition of myopic maculopathy was given by Avila in 1984. That was the first definition, and it went through the stages as M0, 1, 2, 3, 4, 5, progressively with choroidal pallor and tessellation, then posterior staphylomas, Brooks rupture, and then choroidal atrophy and large atrophy. But we know that this sequence of events are not always longitudinal. So another classification was given as categories, not as stages. And they had similar classifications: tessellated fundus, diffuse, patchy atrophy as 2 and 3 respectively, and macular atrophy as category 4. Plus signs were added because this could be seen at any stage. So lacquer crack LC, myopic CNV as MCNV, and FS as Fuchs spots, they were added as plus signs in addition to the categories. This is just to make the understanding or the language common between discussing retinal physicians. So anything which is category 2 or above with the presence of a plus sign or presence of posterior staphylomas was then labeled as pathological myopia. So whatever we start with, whether it is tessellated fundus, which might result into diffuse choroidal atrophy, lacquer cracks, which may result into patchy atrophy, the end result is usually a myopic CNVM with macular atrophy. So this is what we need to intend to abort at certain stage. And once the myopic CNVM started, we all know what is the treatment. A very elaborate and comprehensive classification was given by Ruiz Medrano. They, just like TNM classification for tumors, they gave classification as atrophic component, tractional neovascular component, which are independent of each other, but can coexist at different stages. So atrophy was with no myopic retinal lesions as A0, in a A1, 2, 3, 4 as like described in the previous studies. And tractional component was inner or outer foveal schisis as T1. When both are present, T2. When foveal detachment is present, is T3. T4 as full thickness hole, and when coexisting with retinal detachment as T5. Neovascular component with just lacquer cracks N1, and active CNV was labeled as N2A, and scar was N2S. So here are a few examples, and I will not go into the detail, just giving an just understanding that these lesions can coexist, and the classification can vary, as in first example A1, T2, N0, N0 where there is no CNV. And in the second example, you have an active CNV, which is 2A. So these are more examples here. So I'll just skip in the interest of time. Atrophic myopic maculopathy, we understand that it is the consequence of myopic choroidopathy or myopic CNV. It is associated with staphyloma, progressive choroidal thinning, and excessive elongation, which both of them usually coexist together to result into atrophic myopic maculopathy. There are certain systemic factors like BP and advancing age which can contribute to this. So not all atrophies in myopic eyes are atrophic maculopathy. This is a very well circumscribed symmetrical mirror image kind of picture.
What happened? We lost connection, huh?
Yes, ma'am, I think so.
Could you call him? Well, Murugan, could you call Dr. Jatinder?
Yes, ma'am, I call.
Ma'am, while we are waiting,
Yes. Yes.
can I, we were
Yes,
just talking
yes,
so
yes.
much about lifestyle modification.
Yeah.
Dr. Bhanu ma'am, actually just 2 days ago, she told me about a very interesting case. We always think about the near work. We are not thinking about the sedentary aspect of their lifestyle. Bhanu ma'am, please can you share with us that anecdote that you just told me?
See, I mean, this is regarding diabetic control. What she had, I think, she shared on the screen about reduced carbohydrate intake. So Dr. Bhujan Shetty was so much into reduced carbohydrate intake, reversal of diabetes. I have 4 teenagers with a glycosylate hemoglobin of 7. They came to me with a -3 for the first time. So there was a confounding effect. Is it due to lens hydration, or am I seeing a real myopia? I got their excellent checked. Then I found out later on, I asked them, parents, what were they doing for all these years? Last 2 years they were not really overweight. They were okay for their age. 15 years, 14 years.
Dr. Jatinder, connected?
Yeah. I'll tell you later on.
Yeah.
Am I audible? Sorry, lost the network.
Yeah. Yes,
Okay.
Jatinder.
So as I was mentioning, not all atrophies are myopic maculopathies. They could be cone dystrophies. This is an example of a very large atrophic area at the macula, which was actually a BT's crystalline dystrophy. We can see the crystals around the edge of the atrophic area around the macula.
Can you go full slideshow, Jatinder?
Yeah, sorry, ma'am. So sometimes foveoschisis can be associated with lamellar holes and full thickness macular hole. A careful scan with the OCT through all the lines, the raster lines, will give us an idea if it is a full thickness hole, which becomes an indication of for macular hole surgery in such eyes. And the presence of foveoschisis usually indicates a poorer prognosis. In a large area of atrophy at the edge, sometimes you may see a speck of hemorrhage, which can be very subtle, and FFA will identify that as a CNV, and this is an indication for treatment with anti-VEGF. Sometimes the CNV can be very subtle, and very careful OCT scanning through the area of interest will reveal that the myopic CNVMs are usually not associated with a lot of intraretinal or subretinal fluid, and just mild amount of so-called subretinal hyperreflectivity or some hyperreflectivity in the outer retinal layers is all that would be an indication of a myopic CNVM. So any CNVMs, when present, we have to go with treatment with anti-VEGF and then monitor them closely. So when you have subretinal fluid, not all is CNVM, and this is a 34-year-old woman presented with non-resolving fluid at the macula, in spite of multiple anti-VEGF injections, and you don't see much on no significant CNVM like lesion in the outer retina. And if you do the vertical scan, it picks up what is called as the dome-shaped macula. So this is the dome-shaped maculopathy, and the orientation of the dome can determine what the scan will pick it up. So if in the left picture, the horizontally oriented dome, the horizontal scan is not going to pick it up, whereas the vertical scan will detect the fine. So the key take home is that if you in all myopic eyes, wherever you do suspect a dome-shaped macula or even otherwise, do both vertical and horizontal scans. This is a very similar and related pathology, that is tilted disc maculopathy, and it can be picked up and very well on angiography and fundus autofluorescence. This is another woman, 36-year-old. Typically, this disease entity is common in myopic eyes and especially young women. And you see this fluid presented with metamorphopsia and photopsias. Vision is not significantly affected, but subjectively, vision was quite severely affected. So on FFA, you can see picture which is what is identified as punctate inner choroidopathy.
1 minute left.
Yes. And if you see multifocality of large hyperfluorescent lesion which on FFA which leak profusely, this is the entity which you should be suspecting, not CNV. So this is another some curio pieces. You can see this what is called as radial ascending tracts emanating from the staphyloма edge, also called as rates. This is something which is absolutely rare, and something which is relatively less rare is peripapillary intrachoroidal cavitation or staphyloma. The importance is that these findings can be associated with field defects which are stationary, and it needs to be differentiated from the glaucomatous field defect, which is another entity which can be associated with pathological myopia. So to conclude, early and aggressive treatment of myopic CNVM helps reduce the progression of atrophy. This is all we have so far for these eyes. High index of suspicion of an alternative diagnosis should be always be kept in mind. Timely and judicious intervention and use of LVA whenever needed. Thank you so much for your kind attention.
Thank you very much, Dr. Jatinder. That was a very detailed talk, and it was wonderful to hear all that you said. Wanted to ask Dr. Chetani, we know that high myopia is something not very common in young infants, more in young adults and adults. So does that mean that you would request for some electrophysiological tests or genetic counseling or imaging in children in families of myopia? Dr. Jitendra? Dr. Chetani, are you there? Dr. Rohit?
Yeah, sorry, I couldn't completely get part of the question.
So he was talking of high myopes and the different retinal presentations. So we do know that very high myopia doesn't occur in young children. It occurs more in young adults. So, but then, is there any sense of doing some electrophysiological tests or imaging or genetic counseling in families with high myopia, children with high myopia?
So we do see some infants or very small children with very high myopia, but usually that is associated with preterm delivery. So ROP children, even if it's a regressed ROP, particularly I believe laser, Dr. Jatinder would confirm, but laser has been shown to be associated with high myopia or progressive myopia in very, very small infants and children. So we are seeing a bit of children in the second year or third year with high myo. And of course, you must rule out the fact that there may be any preterm delivery or any other association like that with them. And for them, we need to follow up to see whether they are progressing or not. So there are some studies on the fact that these children do not have progressive myopia. And even if they have progressive myopia, it's anterior segment in origin. So ROP children and preterm children with high myopia or myopia is usually anterior segment. So in them, axial length monitoring is very, very important. So confirm first step, confirm progressive myopia. 2, confirm it's progressive axial myopia. In any child of any age, axial myopia should not be corneal and keratoconus like has been discussed before, or anterior segment in origin like in ROP or very preterm children. For adults with myopia, yes, if there is a visual dysfunction, you may require to do fields or again, if the myopic fundus is associated or correlating with the severity of the visual loss, maybe you're not going to do anything. And as Dr. Jatinder said, good refraction. In fact, refraction is the sheet anchor management for myopia. And of course, if severely macula affected, then LVA accordingly. But if the visual function doesn't appear to be correlatable with the apparent findings, more detailed investigations with OCT and or functional tests like MFERG or electrophysiology may be necessary, because you must explain why the vision is subnormal in these patients.
Yes. Dr. Swati, on to you.
Sir, in case, as ma'am was saying, if there's a family with high myopia, the children are less than 10, they're having high myopia, how much sense would it make to look for things like Ehlers-Danlos or Marfan's, those kind of genetic associations? Because here we don't have, in India, we don't have much of a trend of genetic counseling as much as it is in the West. What would you recommend, sir? Do we send to a pediatrician every time we see a high myopia? I'm talking about turns of 6 or 8, the child is less than 10 years old, but having a true axial myopia and may not be having much of other Marfanoid features. Would it be doing a disservice to the parents to not get them worked up?
So I'm not sure there is a definitive indication for doing all this extensive workup. We know that a lot of myopia is genetic. I mean, at least there is some myopia that is genetic in origin. And that may just be a sporadic myopia, which is non-syndromic and not associated with any other syndrome. So actually, because this would be like shooting in the dark. So next thing you're doing is you're doing a whole genome workup, genome analysis, and then, getting equivocal findings. So I would say that myopia being definitely having a genetic role to play, even in those who are having a family history of just mild or moderate myopia and not syndromic or very severe high myopes, there is a risk that the subsequent generation may have a higher myopia and maybe high myopia and eventually may progress to retinal changes. So, but if the parents have retinal changes, the risk is that they may develop retinal changes. So I'm not sure if there is any clear evidence that, a major genetic workup is going to make a difference, as myopia is polygenic in its inheritance. And unless you're clearly suspecting a syndrome, I would say that, it may not make that much sense for every child. But yes, selectively, if you have a suspicion, you should go ahead and pursue it, because it's important to identify syndromic myopia early, because that would require, awareness and interventions of a different kind.
Yes, thank you, Dr.
And in addition, also as as Dr. Rohit sir said, in addition to ROP and lasers, there can be a glaucoma also, which can be responsible, which we need to. And I just wanted to ask question to Dr. Jatinder, that how frequently do you see macular hemorrhage in children?
It's not so common, but if whenever there is a like a rapidly progressive myopia is what when we when we are suspecting something at the macula, but typically it's not so common in the pediatric age group. I would just want to add to the answer Dr. Rohit has given for Dr. Swati's question. Though we do not indulge into doing investigations on genetic front, but whatever is possible in the clinic, we should probably try to attempt and do that. So look for any facial dysmorphia or any skeletal abnormality. Sticklers is very common. So looking at the dental structure, looking at the vitreous phenotype, if it gives you a clue that it is sticklers, you can be that much more vigilant and call the patient at more frequent follow-ups as compared to the other general pathological myopia guides.
Yes. Thank you. Thank you, Dr. Jatinder. Dr. Bhanumati, you were telling us something, and could you complete?
No, this was about lifestyle changes which doesn't affect the eye alone. And I meant about diabetes in general and all those metabolic syndromes which can cause. So these were teenagers who were on 6 hours of online class, 6 hours of gaming, your soda, everything. And the father, I have now decided to take the family history. If one of the parent is an early diabetic. So all the 3 children had parents, father who was detected to be diabetic, especially in their 40s and 30s. So when I told the parents, let me get I'm not going to give the glass, because you know very well, an uncontrolled diabetes, you don't give glasses. So I thought, why is this sudden thing in a 10th standard child with -3 who's never worn glasses? Parents are not myopic. But axial and diagonal was 25. Glycosylated hemoglobin was 7. So this is how I think we should be happy. We get more confounding features like this, especially in teenagers. There are studies which are shown in the US that teenagers have fatty liver disease. 2 teenagers have undergone liver transplant also, all due to this. So I have had cases where we could not give glasses because of the when blood sugars were very high. So after the blood sugars come down, there's a myopic shift, there's a hyperopic shift. So these things add to a confounding factor, especially in teenagers. you think it's accommodative spasm, you put them on atropine, some part of that myopia doesn't get corrected. So if it's the axial length, fine. But then sometimes these are the factors which play a major role, is what I feel. I'm going to look into this more now. So because your lifestyle factors, none of them play outside.
Yeah, thank you.
And one more thing is microspherophakia, which can cause a high myopia in early childhood. If it's syndromic, especially I have parents where the axial doesn't explain, the lens is subluxated. Sometimes it's not very obvious. You have the anterior chamber, the central part is a little shallow, mid periphery is deep again. Then you look carefully on the slit lamp, if the child is cooperative, you do see phacodonosis there. Sometimes it's not very obvious. So these are the, I have a child who has this -24, it is a microspherophakia. Slowly the mother came out that she's also undergone surgery. She has an SFIOL now. So most probably it was the spherophakia. This is one thing which I would definitely add in children's.
Thank you. I think Dr. Ramesh Kekunia has joined in. Dr. Ramesh, are you there?
Yes, very much. I'm here. Thank you.
Thank you. So we look forward to having the keynote address being taken by Dr. Ramesh Kekunia, who needs no introduction in the field of pediatric ophthalmology or the ophthalmologists of the country at large. He's the network director of capacity building and also the director of the Child Sight Institute at LB Prasad, and is also a neuro-ophthalmologist. And he is going to be talking to us on progressive myopia and an overview of the current armamentarium. On to you, Dr. Ramesh.
Thank you, Dr. Chitra. Thank you so much for that kind introduction and having me in this webinar on myopia. So I'm going to summarize the overview, what is available at this point of time to treat this progressive myopic condition, which is we are restricting ourselves to only the progressive myopia, which is axial. The talk is mainly around that. So we all know that it's a global epidemic. It poses economic burden on most of the patient, which is lifelong, and also decreased quality of life for various reasons. There are many research initiatives to address myopia. Many people, many institutes, many societies are taking this up. And most important thing here is early intervention is the key. It's not that we catch the train at a later stage, but early catching is very important. And progression may be slowed or prevented to a meaningful or acceptable level. It's never going to be, 100% prevention. I would say meaningful and acceptable level, so that you don't have a bigger or a severe complication of high myopia. That's the whole purpose of this treatment of myopia progression. When you look at what are available, as Dr. Bhanumati said, lifestyle modification is the basic important thing. We need to start even before the child develops myopia. Even at a pre-myopic or hyperopic stage, you need to start, because this puts them at a different risk than the rest. Because if you start the child or a toddler or an infant with 3 or 4 hours of screen time, that child is going to have. Versus if the child has outdoor activities and everything from early life, their chances are not never, but we can reduce this. Along with that, there are 16 to 18 permutations and combinations of treatment available for this arresting or stopping or delaying myopia progression, in the form of, on the top you can see pharmacological or optical correction. And obviously it starts with spectacle or contact lens correction. And also there are orthokeratology, and combination of these are available. So the burden to this, I think, can be reduced by majoritarily by changing the lifestyle. That is the first part of any treatment for myopia progression. This is a base of model. I put it for you. Do a good refraction, torch-led examination, axial length evaluation, look at the retinal peripheral refraction, and also look at all patients with, rule out convergence, accommodative, or esophoria in all of these patients. As we discussed earlier, never underestimate the family history, because family history puts the patient into moderate risk, mild risk, and severe risk of progression, and also our good refraction, cycloplegic refraction, including central as well as peripheral refraction. And then you can suggest lifestyle changes. That's as a first base approach. Then spectacles, then optical treatment, the pharmacological treatment of eye drops of various diluted atropines, and then bifocal whenever the patient has esophoria. Then there are optical modalities like DIMS lenses or Holt lenses. And then on the top, we have orthokeratology. And as I said, sun remains the very important factor. Sunlight, that's a very, very important factor of myopia progression prevention. More and more evidence are coming even to light therapy. Probably one day I'll not be, surprised if there is a naturopathy for myopia in terms of various shades of light. And sometimes we need to give a combination of lenses, that is optical or pharmacological, or sometimes even contact lenses we might have to, the role of which is not very clear, but one must consider in this. So in terms of evidence, more of this evidence are coming. But once there is evidence, how they practice depends upon, are you having this habit in the sense, if you are having a special profession, like if you are an ophthalmologist, you will go mostly into pharmacotherapy. If you are an optometrist, you will go into, you can just change the lenses to, Myovision or any kind of brand lenses, you can put it. And also availability and the affordability, because some of the countries, the low dose atropine is not available. In India, fortunately, 0.01% and 1% is available. At this point of time, 0.05% is not really available. But if you look east, in eastern countries, most of them are giving 0.05 because there is more and more evidence coming that 0.05% atropine works. Sometimes think, okay, for every patient, I'm going to give optical correction. So there are a lot of things. Even if there is evidence, the actual practice becomes what you see in this slide. Just if you look at, if you want to summarize, there are 7 points in the myopia progression control armamentarium. Number 1, and the foremost, sometimes it looks very simple, identify a case of true axial myopia. As the discussion was going on, there are some patients, we don't know whether it's corneal or lenticular myopia. Where it works is where we have evidence is the true axial myopia. You do your, biometry, you do the cycloplegic refraction, you do a thorough slit lamp examination. You also look at, during biometry, look at the lens thickness. If it is too thick, like 4.2 or 4.3, you are looking at a case of microspherophakia. You're not looking at a axial myopia. If you are looking at, irregular astigmatism, you are looking at mostly a keratoconus. You are not looking at axial myopia. It may look very simple, but this is the most important factor. True axial myopia, which is not syndromic, That's the first step in identifying for the treatment armamentarium for myopia. Second thing is identify the risk factor for myopia progression. When you call progression, it's axial length progressing more than 0.1 millimeter per year, or refraction going more than 0.5 diopter per year. This is what are the risk factors for this? We need to see. And the third thing is whether there is parental myopia. When I say when both the parents are high myopic, for example, the father and mother are more than 6 diopters, then the child becomes a very high risk at the beginning. Even if the myopia is 0.5, I'll be a little bit aggressive in that particular child, versus both the parents are absolutely emmetropic. The child's refractive error is 0.5 or 0.75. I will always start with the natural things like outdoor activities, less screen time, and things like that. Versus if they have a high risk for progression, then immediately I will put them on some kind of optical or pharmacological treatment. Then, what is the near work the child is doing? Everybody asks for the near work, whether it is reading or screen time. One important thing I must tell that most of the kids, not all the kids, some of them read lying down. When they lie down and read, their distance becomes even more shorter. They have more risk. So I started asking the patient, are they lying down and reading, night reading? This is more risky than with the daytime or with a lot of light. If they read, it's different. Always try to do a relative peripheral refraction. If there is one, try to rule out. More and more cheaper options are coming to check the relative peripheral refraction. Use one of those, use them, and identify both central refraction as well as peripheral refraction. Always rule out lag of accommodation and esophoria by doing a cover test. The fourth step, this is the summary of my whole presentation. If there is pure axial without any relative peripheral hyperopia, you can start with low dose atropine. If there is relative peripheral hyperopia, defocus spectacles are probably better. If there is a lack of accommodation, as you can see in this slide, central distance EDOF design lenses or bifocals, PALS spectacles are better. If there is pure near esophoria on cover test, bifocals are better. Rest of the conditions, you can give orthokeratology up till -10 diopters. More than that, it becomes difficult. This is the recommended appropriate treatment of pharmacological, optical, or just a different lens design. These are the 4-5 simple things you can do in your practice. Out of the 7th, the 5th point is monitor the efficacy of your treatment. Either it is atropine or it is defocus spectacles or bifocals. You have to see what is good treatment, what is poor response, what is good response, what is poor response, and then look at what is to be continued. And it's not a 6 months course. You might have to continue it for 3 years, 4 years, sometimes even 5 years or 6 years. And the 6th point is you might have to think about combination. If one of them is giving a poor response.
1 minute left.
No, he's not. Vel Murugan, he's got 15 minutes. So I hope you're keeping track of that. On to you, Dr. Ramesh.
Yeah, I just have 2 more slides. That's it. So, and then when to taper also, we need to. More or less, I would say 2 to 3 years of stability. Up till around 13 or 14 or maybe 15 years, I would try to, stop this myopia treatment trial. And then this is a short summary we have made. Just a mnemonic is impact. Identify true axial myope, mark the risk factor, pick the progressive myope, appropriate myopia control strategy, and then consult and look at the response rate and combine other treatment modalities and monitor them regularly and taper before you completely stop the control strategy. This is the impact guidelines for myopia control using different things. And the last slide, this is by my colleague Pawan. Master, measure, monitor, and manage. Master means understand the multifactorial nature. That's why you need to do all these tests, customize your treatment for that particular myopia. Measure, estimate the possible myopia risk factors in that particular patient, whether there is esophoria, whether there is peripheral refraction, or is it true axial myopia. Then monitor closely every 3 to 6 monthly. I would say most of us practically do it every 6 monthly, and manage with appropriate anti-myopia strategy. Clear myopia management is beyond providing single vision correction. So this is the 4 M's you should remember in the myopia management. Thank you so much for this opportunity to provide an overview of what all are things available for treatment of myopia progression in children and even in adolescents. Thank you.
Thank you. Thank you, Dr. Ramesh. That was such a crisp, wonderful talk. Swati, do you have questions to take, or Dr. Rohit?
Yes, sir. Dr. Ramesh, I have a practical consideration. So when we go through most of the studies regarding these kind of myopia control glasses, they always exclude the children with intermittent or manifest squint. So when we have a child with intermittent exotropia, progressive myopia, we know that both of them are related. Have you personally dispensed glasses like this? What do you suggest we do? Does it worsen their control, the peripheral defocus? Do they start becoming more exotropic? Do we try the glasses and take them off?
Yeah, this is a everyday kind of situation where especially the strabismologists face. Most of them have mild to moderate myopia and they are in their 6 or 7 years of age. What I try to do is, if it is a very mild intermittent exotropia, for example, when I say mild, less than 15 or 20 prism diopters with the good control, I really don't change the anti-myopia strategy management. Really does not really matter. Either it is optical or, you are starting pharmacological. If it is beyond that with the worse control, probably what happens is if they have a optical correction, it'll come in their way, it might cause. So I tend to put them on only low dose atropine rather than anything else. Having said that, before that, I must clarify what is the ratio of, in my practice, what is optical treatment, what is pharmacological treatment. Having ruled out everything, still around 50 to 55% of the patients, we still give pharmacological treatment. If that just 35 to 40 or in a given day, I might have given atropine for everybody also. So it varies. If it is moderate to severe, coming back to the question, moderate to severe, either intermittent exotropia or sometimes, strabismus associated with myopia can also have a esotropia. In this patient, especially in esotropia, I try to avoid atropine. I just try to see whether they have any amblyopia and everything. I correct that before really starting anything. Like if they have 35 prisms of esotropia, I would try to do some correction for that and then start this treatment. Intermittent exotropia, moderate to severe, I stick to pharmacological treatment for that. This is what I do. I would like to know anybody else differs or they have any other suggestions. Rohit or anybody, they can comment.
So I think broadly this is what we follow. It's just that I would always be far more sensitive for any other problem and managing that if I have a management for that before I'm, kind of thinking, contemplating and deciding on myopia, because myopia is a chronic problem. So I'm looking at an intervention depending upon the age of presentation for from somewhere anywhere from 4 to 10 years, depending upon when the child is presenting to me. Whereas if we are dealing with, say, amblyopia, that's a treatment modality which I'm looking at intervention in 6 to 8 months. So that takes absolute priority. I would not, kind of blindside the parents about myopia and everything like that. I would really insist on amblyopia therapy, and that's something we must remember. The parents should not be confused with a whole lot of interventions. The most important thing is vision. The eye needs to be able to see, and amblyopia therapy. Esotropia, again, manage which whatever way it is. If it's accommodative management, or if it's surgical, early surgical intervention, and then think of in intermittent divergence squint. There is a wee bit of challenge, as Ramesh said, that there is a bit of a challenge in our deciding on that. Again, just because by the sheet anchor of the interventions that we have done, predominantly for us also more than 2/3, even now interventions are optical, are pharmacological as compared to optical. And I have a lower sensitivity towards, operating intermittent divergent squints who have progressive myopia, because, like I said, I want to get over with that much faster than rather than start talking to them about near exercises, fusional versions exercises, and increase near work, which actually is counterproductive when I'm talking about their, myopia management. So I'm a little more sensitive towards interventions in intermittent divergent squint with progressive myopia. And I would still, as Ramesh said, would prefer pharmacological interventions to them if I am intervening as compared to an optical intervention.
Thank you. Thank you, Dr. Ramesh. Thank you, Dr. Rohit. We shall now go on to our next speaker. I would wish if Dr. Ramesh could be with us to add his words of wisdom. Dr. Savneen Kaur is our next speaker, who's a senior consultant at PGI Chandigarh, and she's going to be talking on development of myopia in premature infants, observations and recommendations. On to you, Dr. Savneen.
Thank you.
Network is okay? The network is not all right, I think. Dr. Savleen? I think, are you?
Can you hear me? I'm sorry, I think my internet broke in between.
Yeah. Can you share your screen?
Make it full screen, ma'am.
Yeah, go ahead.
Yes.
No, again, it has gone to the previous screen. Could you make it full screen now? Do you need to check on your network?
I just lost my internet for a second there. Just give me one. I'm very sorry. Can you hear me now?
Yeah, we can. Can
Sorry.
you go to slideshow and start your talk here?
Yes.
Okay. I'm very sorry about that. So I'm going to be talking about something which I think Dr. Rohit just stressed upon, development of myopia in premature infants. We often, as pediatric ophthalmologists, face this situation, for instance, of a 15-month female presented to us for a visual evaluation. And you can see the child is fixating and following well. But the child gives us a history that he was born preterm, diagnosed as bilateral aggressive posterior ROP, and then received an anti-VEGF, followed by a recurrence for which the child was lasered. Now you see that the child seems to be fixing following well, and there is no strabismus, but has a refractive error of -4 in both eyes. The child is 15 months old, and a lot of questions come to our mind when we see such a situation. The most important being, is it normal for this child to have this refractive error? If it's not normal, why is this child having this refractive error? Is it because of the prematurity per se? Is it because of the ROP, or is it something we have done with our treatment? Do we prescribe in this child, and how much we prescribe, and how does this refractive error progress as compared to a normal term-born infant? So I'll take these 4 questions in my presentation. The first being that if we have a preterm born child, do we expect the child to be myopic? So the last step of emmetropization that happens that makes the child a little hyperopic is actually at the last month of gestation. Because these children are born preterm, so this gets arrested somehow in the last 4 weeks of gestation. So regardless of whether they develop ROP or not, a preterm child is at a risk of developing myopia to the extent of 10%, and astigmatism even more than myopia. You have a lower birth weight child and you see a lower gestational age, there are more chances that the child is going to be myopic besides the genetic and the environmental factors. The second question is that if we have ROP combined with prematurity, what happens to the refractive error now? This case is a 6-month baby. Here, pole is left and the whole of the red. There seem to be no structural sequelae and the macula is normal. The child is 12 along with an alternating strabismus. So in prematurity, what happens is the anterior segment is somehow compensating for the posterior segment and states for this myopia. But once you have ROP, a disease which kind of laser it by, say, you give anti-VEGF and you stop the progression of the disease, this exit progression is somehow halted. So in a child with refractive error in ROP is more myopic to be expected to the extent of 21 to even 100% in some cases, and nearly half of high myopia. The more structural sequelae, the more myopic they are likely to be. Now, why do some of these children have high refractive error and some have low? So you see a child, 2 children who are comparable, both born at the same time, one having a refractive error of -8 and the other having a refractive error of just -1. So there are a lot of combination give rise to this myopia. There are a lot of studies which have tried to analyze what's responsible, and if we can change one factor to make them less myopic. We did one study of our own where we looked at the refractive error in children who had a history of 7 years post ROP treatment. Nearly 3/4 of them were myopic, and half of them having myopia more than 6 diopter. More progressive disease seemed to be causing more myopia. But the interesting part was that it was not the axillary length, but the lens thickness that was actually corroborating to the myopia that these kids have, along with a steeper cornea. So the lens thickness and the axial length does not seem to contribute to the myopic status in these children. So steeper corneas, shallow anterior chambers, and thicker lenses, that is what is causing myopia in these kids, and not actually axial elongation. Now, we often ask these questions, and parents often are inquisitive as to whether we can do something when a kid with ROP occurs. We try to look at prospective evolution of refractive error in these children by actually screening them before they were treated for ROP and then following up for a period of 1 year. We screened about 122 infants, and we tried doing the retinal up to about 1 year from baseline. Most of these ROP, and some of them they got treatment, some did not get treatment, and some did not have ROP at baseline. So we made 3 groups. One, the children who had no ROP. The second ones being the ROP, which was group being the ROP, which was treated with laser. Interesting to see that all these groups, all these babies, lasered or not, they were comparable as far as their axial length and myopia was concerned. The more severe disease had more. Looked at their progression over 1 year. We saw that the axial length in the group that was lasered did not progress much, and the cornea somehow did not steepen much. So, when born preterm or term, the cornea somehow flattens, the axial length elongates, but this was not happening in these kids who had RP, which was treated. RP with laser had the shortest axial length at 1 year, with the smallest decrease in keratometry. We also saw that this increase in myopia was maximum in the group that was lasered. So if we look at the proportion of children who are lasered, and they seem to be rising titers of myopia you see at 1 year. On the other hand, you do see some emetropia in children who are born preterm. So the trend was that children who do not have any ROP, they are myopic to begin with, but they become less myopic over time. Children who have ROP but do not need treatment, they are less myopic, but they become more myopic or reach a plateau. The ones that are lasered, they become less myopic to high myopic. This progression is important because it's not axial, hence pharmacological therapies like atropine, which we are talking for other axial myopia, are not probably indicated for this subgroup of myopes. So the normal stimulus for the eye to grow is by the peripheral retina, which is now somehow ablated by laser, and so it causes a blurred image and no axial elongation stimulus is given to the eye. The posterior segment growth is arrested, the axial length is shorter, the cornea is steeper, and the lens is more anteriorly placed. There is no sole trigger, there are all these factors combined. And the ideal control group would be a group which has ROP and we don't laser it. So it's kind of unethical to do that. And we have a similar scenario. The paper that actually propagated anti-VEGF in ROP, they claimed that we have high myopia in eyes with laser than in eyes which received bevacizumab. So it's not actually a rule because all these studies have been from variable subcontinents with variable severity. We do see emetropia in laser also, and we do see high myopia in anti-VEGF also. To conclude, RP prematurity and low birth weight development of myopia in these children. A severer disease will cause more myopia. Predicting a refractive error will be difficult, but we believe that pharmacological therapies will not work for these kind of myopes. And intravitreal therapy might be causing less myopia, but it's just a possibility as of now, but not actually a rule. My acknowledgements to my mentors at PGI. Thank you.
Thank you. Thank you. That was a lovely talk too. At times the network was going.
So sorry about that.
Really interesting for me, especially. I think there's something all of you are more familiar with it. Dr. Jetani, you have keep going. I've never asked you a single question. So are you there? I think he keeps going back to his patients, I think. So, well, Shreya, would you like to take this question? She's also not okay, Rohit.
Yeah, ma'am.
Yeah. So, there is some thought that giving intravitreal injection has a role in decreasing the progress of myopia. So, if so, what would be your kind of follow-up? How frequently are these injections given, or how? Yeah.
Yeah. So I really don't want to take up this question because I'm not dealing in my institute for ROP cases. So I'll just switch over to Dr. Rohit. Dr. Mehul takes care of ROP cases in my institute. So I just
Yes,
directly
Dr.
referring him. So
No, I would say that, I mean, like, myopia, I mean, again, you're treating, like we were talking about other diseases. ROP is treated by the treating surgeon, usually the retina person, but whatever best modality they feel fit. Most of them are actually shifted to anti-VEGFs as compared to lasers. And whatever association there is of lasers, as Savleen has pointed out, is there, but we are seeing much lesser use of lasers in these children, which may be good. But as Savleen has also pointed out, and as we have all in the earlier part also we talked about, much of the myopia in these children is anterior segment in origin and not really axial. So when we are looking at myopia progression interventions, then you need to be sure that the myopia that you are, the progression of myopia that you are identifying is axial in origin by doing biometry. So that is the most important thing before you start treatment in these children or in any child. Confirm progressive myopia, axial myopia before any thought of intervention. If in doubt, follow up for about 6 months to confirm increase in axial length. That will help us to confirm the diagnosis of progressive myopia, which requires intervention for that. And two, you will also understand the rate of progression, which will help us in decision making on the treatment, because once you start your intervention, that's the only way you'll get to know whether you're making a significant impact by change in the rate of progression, which is again the key intervention outcome measure that you're looking at. So exactly that.
Yes. Swati, you want to take any question or shall we move to the next?
Yes, ma'am. This is actually for Jatinder, sir. Because many of us watching a pediatric ophthalmologist, we may not be in institutional practice per se. Sir, if a child has received bevacizumab, and we know that with these injections, there's a chance of late recurrence. Up to what age do you want us to refer the child back to a retina specialist? Because the last studies that have checked are up to about 52 weeks, that is a year. So do you recommend that every 3 months or so we ask the child to visit a retina specialist? If they've already received bevacizumab elsewhere, they're coming to us now just for a general checkup. Then if it is 9 months old, 10 months old, what do we need to look for? What says there's a recurrence?
Dr. Jatinder, are you there?
Yes, ma'am. But I didn't get the question clearly. I don't. Should I repeat, or Swati, will you do that?
Sir, if a child has received Avastin or bevacizumab injections, and since there are multiple studies that say that they may have late recurrences of ROP, until what age should we be sending the child back to the retina specialist for a regular follow-up? Studies say up to 52 weeks, 54 weeks, there are recurrences.
I get it. Once the ROP is labeled as stable and it's not going to progress and it is fully treated, then we need to look at the refractive status. I think baseline refractive status I do at 1 year and then at 3 years. I call the patient and the child back at after the third birthday. And if there is any the pre-myopic, if it fits into the pre-myopic definition, then I would probably ask to get a axial length done as a baseline and then follow up from there. So it's not a 3 month. I don't think 3 months. 3 months is too short a follow up to like document any meaningful change in the axial length.
No, not about the myopia, sir, about recurrence of ROP.
I
50
think
to
it
54
doesn't
weeks, there
fit
are
into the
reports.
purview of this discussion, but ROP is a separate seminar altogether. But
Okay, sir.
still answering your question, that the vessels have to be fully, the retina has to be fully vascularized, and then is at that stage only we call the patient as stable. And once it has been labeled as stable ROP and it's not going to progress vascularized completely, then there is no need for further follow-up just for ROP sake. Then we just monitor it for the myopic change if at all.
Thank you, sir.
We go on to our next speaker, Dr. Shailesh, who's a senior consultant at Shekhar Eye Hospital, JP Nagar, Bangalore, and he's going to talk to us on something even more important, glaucoma and myopia, and update. And we know how often they coexist, and let's know what he has to say. You could go to slideshow and
Shailesh, you are mute. You need to unmute.
Yeah. Shailesh, we can't hear you. Lot of network issues today.
Yeah, okay. Hello, everyone. Yeah, thank you, Chitra ma'am. It was a wonderful, thank you for inviting me for this wonderful, wonderfully conceptualized myopia panorama with a lot of interesting topics. And I will be dealing with glaucoma and myopia and uptake. And we all know glaucoma itself is a big problem. And to add to that, a double whammy, myopia is there. And that causes a lot of problems in dealing with these kind of cases. I'll just touch upon the salient features of how a glaucoma is presented in myopic patients. Myopia and glaucoma, we all know, are the commonest eye ailments. They constitute a majority of them. And it is increasing in the East Asian population. That is the worrisome fact of it. Glaucoma in myopes have variable progression and as compared to the OAG alone. And they also come with a diagnostic and management dilemmas. Now, the morbidity of myopia is not only restricted to the optic nerve, it also has got myopic macular degeneration, retinal detachments, cataracts, and amblyopia, strabismus, heavy eye syndromes, and so many other things which other speakers will deal with. I will touch upon the most important part of this myopia, that is glaucoma. Globally, we know that myopia affects 22.9%, and in 2050, it is going to affect 50% of the population. And in extrapolating to Indian scenario, it is 7.5% in children 5 to 15 years and 8.5% in urban and 6.1% in rural areas. It's again increasing by 2050. So we have to be very careful about this situation. A lot of studies have associated with this myopia and glaucoma, and they have come up with different linkage. So commonest being the Blue Mountains eye study done in Australia, where glaucoma is present in only 1.5% of eyes with myopia, whereas in 4.2% eyes with low myopia and higher number of 4.4% moderate to high myopia patients have glaucoma. In Beijing eye study, high myopia of more than 6 diopters have a high risk of developing optic disc glaucoma. Singapore Malay's eye study, where Southeast Asian population has been touched, where there was high risk of 3 times higher risk of developing open angle glaucoma when the myopia is more than 4 diopters. This graph shows in myopia how the refractive shift happens as the age also increases. So this is what at around 15 years, they all tend to stabilize. Along with myopia, we know that it is open angle glaucoma. That is one which we see. Many times we see a young individual with pigment dispersion and they won't have any myopic symptoms. And once we carefully do refraction and all, we pick up the myopia. These are young males with moderate myopes, and they have spontaneous fluctuation of IOP and transient blurring of vision on and off, especially when they do exercise on gym or they run or jog or some other issues. And they have high IOP without any field loss. So we should be mindful of this situation with a young myope having some blurring of vision, having pigment dispersion syndrome. There are a lot of associations I would like to tell with myopia and intraocular pressure. If the pressures are less than 20, and if the myopia is moderate to high, there is 2.2 odds ratio of developing glaucoma. Whereas if the IOP is more than 20, and if the myopia is high, then there is 4.27 times the chance of developing glaucoma. Same thing with axial length and IOP. So if the IOP is less than 20, and if the axial length is 25.5, there is 2.85% chance of developing glaucoma. Whereas if the IOP is high, along with that, the axial length is also high, it is 16.2%, exponentially high. So axial length and IOP are very important factors. Now, myopia also comes with its own diagnostic dilemmas. In clinically,
और क्या अब तो हमें कोई इनवाइट
Please,
करता नहीं है.
others, can you unmute yourself?
दो हारे हुए.
Rohit, you have to mute yourself. Yeah. Okay, Dr. Shailesh.
am I audible?
Yeah, you're audible,
Yeah.
Dr.
Yeah. Clinically, we have to just measure the IOP at the various points of time, not only in one time, morning, afternoon, evening, whenever it's permissible to have a very consistent IOP values so that we know there is any diurnal variations or not. Optic nerve head evaluation, they bring some challenges which I will explain you later. Investigational challenges are there in terms of OCT of optic nerve, visual field evaluation, and disc photos. Now, there is what makes myopia a very challenging one because of its anatomical predisposition. There is axial length elongation, thinner lamina cribrosa, there is decreased scleral rigidity. And when you see the optic nerve head, we have that nasal insertion, we have a larger disc, we have tilted disc, and we have shallow cupping. And along with that, we also have these kind of peripapillary changes like atrophy, scleral crescent. These are the different types of optic nerves that we see in glaucoma patients with the tilting of the optic nerve, and there is the scleral crescent and then peripapillary atrophy along with macular degeneration. You have a very classical tilted disc, but it is essentially a normal nerve. These are the range of optic nerve heads we see in glaucoma patients, and we get confused whether we are dealing with just a myopic optic nerve or a glaucomatous optic nerve. We have a tilted, large cup, then there is a myopic tessellated background, then we have this increased peripapillary atrophy, and then the staphylomatous optic nerve associated. Again, some sets of optic nerve heads. Now, optic disc area also increases when the refractive error also increases. This is one graph which mentions. Now, what is the other part of measuring the glaucoma is in terms of retinal nerve fiber layer imaging. And the relationship between axial length, spherical equivalent of the diopters, and retinal thickness has been established. I've just come to this last two lines. Average decrease in RNFL happens when there is -7 micrometers of decrease in RNFL per millimeter increase in axial length. And if the refractive error is increased by 1 diopter, there is 3 micron decrease in the RNFL thickness. So RNFL thickness is something like CCT. We also have some evaluation in terms of axial length as well as the dioptric power. So OCT in myopia is also fought with a lot of challenges, like there is RNFL thinning, loss in early signs of glaucoma. Challenges in myopic eyes being that there are thinner average RNFL measurements. It is not well represented in the reference database. So the database contains the normal refractive errors up to 0.5, but beyond that, it is not representing. So we may have some issues here. And they may have a atypical distribution of RNFL with temporal shift in the RNFL fibers. So here is a case of OCT image with enlarged blind spots here, but it essentially the OCT is normal except for a few gray areas here. The other part of evaluation is that visual fields. So we have localized field abnormalities. There are so many other field abnormalities that we see in myopia with glaucoma. High myopia can cause field changes due to ventrally nerve as well as retinal anomalies also. We should be careful about that. Visual field defects that favor myopia only over glaucoma are that there are temporal field defects, usually respecting midline as it is a tilted disc. Then there are enlarged blind spots. But visual field defects that favor glaucoma are typically a nasal step, arcuate scotomas, and paracentral scotomas. So we have to decipher these two things clearly. This is a summary of few of those visual field defects, like this enlarged blind spot, then the arcuate scotoma, and the nerves looks very suspicious, but and here is the nasal step. And here is one case where a glaucoma is being followed up, a myopic moderate to high myope, where from 1999 to 2015, we see that there is inferior arcuate defects, and they consistently present at one point of time. It looks like it is increased, and then again it comes back to its baseline. And the fundus photograph is almost similar to this. Here is the same patient.
With 1 minute left.
Yeah, disc photos of baseline and even after 17 years, almost similar. But what we have to see is that we have to have a serious follow-up of visual fields which will pick up the glaucoma. So progression of glaucoma is also very important because field defects continue to progress despite good iopic control. Moderate to high myopia is a significant risk factor for progression of field defects. This is one case of myopia where there is superior arcuate, and here the fundus looks quite normal, but it's a small disc with a superior arcuate defects. Here is one case with a myopic disc with inferior small notching and corresponding field defects. So we have to correlate optic disc with the field changes. Now coming to the surgical challenges, once we decide that the glaucoma is going out of control beyond the medical management, we have to look into the surgical options that we have to see. We have to be very careful about the hypotony that is usually develops after a conventional trabeculectomy. So to mitigate these risk factors, we require multiple flap sutures, and tube shunts, which we usually use in these cases, also may need to leave patient at a slightly higher IOP intraop, and we should have a low threshold to have a refill of viscoelastic so to maintain the chamber. So there are few things, last few slides. The missing links in glaucoma, many times we never forget to ask for refractive surgeries. Post-cataract surgeries also, patients will have a normal vision in these two situations, but they have not come for follow-up because their vision almost got restored to 6.6 or 6.9 and they won't come for follow-up. Remember that myopic degeneration still persists and glaucoma still exists. Never forget to ask history of any treatment. To start treatment, we have to have a risk-based approach, like discuss the patient, involve them. Sometimes we have to start in young patient where we have a poor follow-up, we have to give medications, and we have to discuss the patient about the pros and cons. Field effects are closer to fixation, we have to treat them. Associated conditions where there is migraine, sleep apnea, low BP, anemia, we may err on the side of treatment. Recent understanding about the myopia and glaucoma is that in the investigation part, macular OCT measurements of ganglion cell complex and macular retinal nerve fiber layer inner plexiform layer complex may provide better glaucoma detection than the standard RNFL measurements. In summary, strong link is there between myopia and glaucoma. Myopic eyes show structural and functional defects that is difficult to distinguish from those caused by glaucoma. Longitudinal follow-up is required in terms of regularly evaluating the IOP, its fluctuations, field defects, consistent field defects, OCT. Be careful about the red eye disease where the temporal and the inferior RNFL converge on the temporal side and cause this red eye disease. Fundus photos are very important in help in picking up the progression. A serial fundus photograph has to be taken. Keep a high index of suspicion, especially in young patients. Surgical options have to be explored, keeping in mind the scleral thinning and the associated hypotony. Now, this is to end with this is an interesting slide, which article, Glaucoma in Myopic Eyes by Arnold Knapp. It was done in 90 years back, like none of us were born. He said that although the diagnosis of glaucoma in these cases is difficult, repeated tonometric and perimetric examinations would indicate the line of treatment. We have not gone far ahead from this statement, which was done 90 years back. Only OCT and few other treatment modalities have been added. Thank you.
Thank you, Dr. Shailesh. That was a wonderful talk and it was interested me a lot being glaucoma.
Yeah.
Then what does it mean? Would you be a little more thoughtful about using mitomycin and myopes with glaucoma?
Absolutely, yes, ma'am. Any surgery, we have to be very careful in terms of maintaining the anterior chamber and using mitomycin. So they are and have a very tight flaps so that hypotony is avoided. Mitomycin is also fraught with hypotonous maculopathy, and we have to be careful, or we have a lower dose of concentration of mitomycin. See, many times we operate in young patients. Myopes with young patients develop glaucoma. So myopes and young patients have got very thick tenons and they have very aggressive reaction. So we have to balance between the hypotony as well as the mitomycin C concentration. But the best way is to have releasable sutures, have a tight flaps so that you don't have hypotony in the post-op.
Yeah. What about IOP measure in those post-LASIK patients? Would you be able to hold on to Corvus or Dr. Ramanjit's concept of measuring the temporal sclera?
Yeah, away from the center. There's one, our dynamic DCT is Pascal one. We also have the ORA's ocular response analyzers, or we also have, and I think you are the best person to tell this also because you do both glaucoma and refractive surgery. And many times we even do our own applanation tonometer and there is some correction factor, just like CCT. We can just underestimates, but at least we have applanation commonly. We should keep in mind that it is underestimating our IOP. So accordingly, we have to adjust to the age, the optic disc finding, visual field changes.
Thank you, Dr. Shailesh. We shall now go on to our next speaker, Dr. Sandra, who's a senior medical consultant, pediatric ophthalmologist, and adult establishment services from Arvind Eye Care Services based at Coimbatore. And she's going to talk on something quite important here, amblyopia management, what's time tested, what's new in relation to this myopia panorama. On to you, Dr. Sandra.
Thank you very much, ma'am. Am I audible and am I screen visible? Yeah.
Yes, ma'am.
Yes. So I'm going to talk about amblyopia, slightly different topic now. Just I would like to tell everybody or ask the audience whether amblyopia is common in myopia. If we think about that, it's not very common because we tend to use near vision. like the myopic people, even those who are high myope, have a good amount of near vision. Hence, amblyopia is not common in myopia as such, unless you have a significant degree of anisometropia or if it is a very high ametropic amblyopia. So let's to go into the history a bit. Amblyopia is a concept which was recognized as early as 400 BC by Hippocrates, who defined it as dull vision. So von Noorden's definition is very famous and known to us all, where we define amblyopia as a decrease in visual acuity caused by abnormal binocular interaction, which occurs in one or more eyes as a result of pattern vision deprivation during the critical period, for which we cannot detect any cause during the physical examination, but in appropriate cases is reversible by therapeutic measures. So it is something where the doctor does not see anything and the patient also does not see. And also to define by a functional perspective, as per defined, it's a visual cacophony of deficits. It involves not only defects in visual acuity, but there are multiple deficits including contrast, spatial localization, fixation, motility, accommodation, crowding, attention, motion perception, temporal processing, so many other issues which maybe we miss out on and just focus on the visual acuity loss. But till date, it remains a diagnosis of exclusion. So the signs of amblyopia, apart from decreased visual acuity, include poor color vision, poor dark adaptation, poor contrast, VP anomalies. There may be a mild degree of RAPD also in denser amblyopes, and that may put us to a little confusion if it is an organic etiology there. And you may have motility defects. That's why amblyopic children, they have poor reading capabilities and they tend to do poorly in the school examination because of problems with saccades, pursuits, and fixation, latent nystagmus, poor accommodation, and eccentric fixation. So it is quite common around 4% of children and school-going children. There is no gender or race predilection, but there can be predisposing factors like refractive error, uncorrected refractive errors, and strabismus. And why it is most important is because it's a very important cause of unilateral vision loss in population younger than 40 years. Pathophysiology is like there is a very dramatic time period of plasticity around 2 to 4 weeks of age. At that point, there is a very rapid development of functional and anatomic organization of visual system, and that's influenced by your visual experience. As a baby, at birth, they do not have clear vision at all. And it's a learned thing. By around maybe 2 to 3 months, it takes for the good fixation and following to occur. So if there is any condition which affects which causes monocular or binocular vision deprivation at this point of time, that results in very dense amblyopia, and also we can see structural and functional alterations in the striate cortex and the lateral geniculate body. So this critical period, it begins at like soon after birth, peaks by 2 to 5 years, and thereafter there is a slow decline till around 12 years. That is why most of the therapy for amblyopia and vision screening should be done very early, very ideally at preschool, even before that if there are high risk factors like prematurity or so. And all this is by the pioneering work of Hubel and Wiesel, as we all know by the experiments. And necessity, why we should treat amblyopia, definitely it's psychologically distressing and doubles the risk of visual impairment if they lose vision in the better eye also. And also as it's a childhood vision loss, improvement or therapy of amblyopia can definitely improve the quality of life as you calculate by the life years and opportunities. Etiology, as you can classify based upon whether the etiology-based classification into strabismic, refractive, vision deprivation and occlusion, and refractive, anisomeridional, and isoametropic. There are other etiologies also like idiopathic, organic, and hysterical, which also can come in. And based on the visual acuity, you can classify as given by PEDIG as early as 2003 into mild, moderate, and severe categories. Mild being like up to 612, moderate 612 to 6/30, and severe between 630 to 6120, or more worse than that. And there are certain phenomena which are unique to amblyopia, including clouding. So crowding is when the single optotypes are shown, the child is able to read them, but in a line, the child is unable to read. This is because of the phenomena of lateral inhibition. So what happens when we test in very young children, we usually test with single optotypes or, picture cards. So that will overestimate the visual acuity. Once you come back to your Snellen's visual acuity or logMAR, then suddenly you may note that the visual acuity is much poorer than what it is. So we need to use cards which have these crowding bars so that we don't get a false overestimation of visual acuity. Another thing with respect to amblyopia is the neutral density filters, where a normal, in people, this vision is degraded by like a line or two, but in amblyopic, you do not find a similar decrease with the neutral density filters. So how to diagnose? The criteria for diagnosing amblyopia? There should be a minimum of 2-line difference on Snellen's or a 2-octave difference in a preferential looking test. And ATS guidelines say that there should at least be a 3 logMAR line difference, because in logMAR, we can pick out smaller differences than what we pick in Snellen's. While coming to bilateral amblyopia, the visual acuity less than 20/40 in each eye is taken as a criteria. But surely in infants, where we cannot test acuity as such, we look at fixation preference and resistance to occlusion. And definitely, the first step towards amblyopia therapy is always a good refraction, correct glass prescription, and rule out organic cause. So with this, sometimes we do find errors of refraction, and we need to be sure and repeat it twice or thrice before we come to a conclusion as to what is the correct glass prescription. After that, there are various treatment approaches, the topic being time-tested and newer treatment modalities. The time-tested ones would be occlusion, first refractive correction, followed by your occlusion and penalization. Drug therapy has also been around for quite some time. The newer therapies are the binocular, where we look at binocular integration, computer-based therapies. So the PEDIG was a group which was started in 1997, where ophthalmologists and optometrists came together to put across guidelines for amblyopia treatment, because before that there was not much of uniformity in the treatment of amblyopia. So when we look at the PEDIG guidelines, they gave very good recommendations which most of the pediatric ophthalmologists still follow. And optical correction alone, initially when we look at a child with amblyopia, we do not start treating immediately. Initially we give the correction, the optical correction. Why? Because both unilateral and bilateral amblyopia will improve initially once you give the glasses, and you wait for 6 to 8 weeks before you decide on the necessity and the duration of occlusion. Because one thing is, you may not need to treat with occlusion at all. Secondly, you may be looking at a lesser degree of amblyopia, and the treatment guidelines may reduce, and the number of hours of patching which you advise may reduce. So similar thing was observed both in isoametropic and ametropic amblyopia. So optical correction may improve. Wait for a period of 1 to 2 months before you start with your patching. Coming to the patching, how much to do? Again, we look at the ATS guidelines, where they said the 2 hours of patching plus 1 hour of neuroactivity is equal to 6 hours of patching for a moderate amblyopia. Similarly, 6 hours of patching with 1 hour of neuroactivity is as good as full-time occlusion in severe amblyopias. So this makes it easier on the family to go with lesser treatment hours. And when you look at treatment of older children, that is beyond the amblyogenic age, that is 7 to 12 years and even 13 to 17 age group, the optical correction alone, there were 3 categories in which the studies were done. One is optical correction alone, second is optical correction plus patching, third is adding your near activity also. And the best was to give a patching duration along with some guided near activity, where active therapy was much
1 minute
better.
left.
Yeah, thank you. So occlusion should be stopped when the visual acuity becomes equal and you get true alternation. But in the amblyogenic age, you give a maintenance occlusion till the period is over. And drugs, atropine is the time-tested drug where you give in moderate amblyopia, where you can give either weekend atropine or twice weekly, works as good as daily. And coming to levodopa and citicoline, lot of studies are there, but there is no definitive evidence if it really works. So the pitfalls of your traditional therapy is decreased compliance, light sensitivity atropine, and difficulty in achieving true equalization because it does not address suppression. And many of them do have residual amblyopia also. The good news is the brain has neuroplasticity and it can change its form and function. So the binocular therapies are based on using both eyes together. Most of the present therapies are into 2 categories, perceptual learning or dichopic therapy. So perceptual learning, where you give a repetitive stimulus, and these are your gabo stimulus, where this particular stimulus is chosen because your occipital cortex is more sensitive to it. And it's an algorithm based therapy where you give like 30 to 45 minute sessions over a period of 3 or 4 months, and they have claimed improvement in visual acuity along with improvement in contrast sensitivity also. The other form is the dichoptic therapy, where you give a single visual percept to both eyes simultaneously and using a red-blue color glasses, and then you decrease the contrast in the good eye, and gradually you are you're making the contrast equal. So these kind of therapies also find a place now in the ATS studies, where the recent studies look at these binocular therapies. So personal experience for me is more with the Binox Amblygo, which is a dichoptic therapy. So here we encourage the kids to play the games for 1 hour at least 5 times a week. And the inclusion criteria, it works well in mild or moderate amblyopia. We have not found much success in severe amblyopias or in strabismic amblyopia with this mode of therapy. The prerequisites are foveal fixation, no tropia, access to computer with a good net connectivity. And before enrollment, we have to do the Snellen and Logmar 4-prism base out test, slit lamp, and fundus and OCT to document foveal fixation. And we can also monitor the way the kids are doing the therapy based on your, you can get all these graphs where you can note the sessions, whether they're doing the requisite number, requisite time, and requisite number of days per week. Every 20 sessions or so, we document back in the clinic to document the improvement. So we have noted a good improvement. Most of these anisometropic or anisomyopes, where we, if there is significant anisometropia, you put a patient on contact lens before starting on therapy. Ametropic amblyopia, even after several months of glass, we're still looking at 612, does improve very well with good improvements in stereopsis following dichoptic therapy. The pseudophakics were 3 cases with partial cataracts, which improved very well. And strabismic amblyopia, we have not got that much success. And like 8 cases we did who have completed therapy, 5 didn't improve and 3 improved by 2 and 1 by 3 lines. So, and all the cases which have improved do get improvement in binocular vision and stereo acuity also. This we have just given for, submitted for a publication. So, it's a case-by-case basis. Technological development is fast improving, and there are still more newer therapies coming. So we need to keep our eyes and ears open for this. And it helps us to better define, understand, and categorize amblyopia. And we have to develop a customized treatment for each patient. Thank you.
Thank you, Dr. Sandra. That was a very crisp talk and detailed all, but I'm not going to take questions because we have a number of speakers ahead and we've been running late. Do stay with us. We'll take some questions at the end. We go on to our next speaker, Dr. Love Puchabe, who's a senior consultant, pediatric cataract, squint, neuro-ophthalmology from Netralayam, Kolkata. And he is going to talk to us on pediatric cataract surgery, the right planning for optimizing long-term visual outcomes. On to you, Dr. Love.
Yeah. Share slide. I'm not getting option of share screen.
Vail Murugan, can you guide him?
Sir, open your presentation, sir, first. Second, you go to Zoom application. Choose share screen option and select your presentation, sir.
He's done it so many times.
Yeah, yes. I got it.
Yes,
So it's visible?
Yes, yes.
sir, make it full screen, sir. Play, sir, play.
So thank you, ma'am. Thank you for giving me this opportunity. And I would be talking on pediatric cataract surgery, right planning for optimizing long-term visual outcomes. And since the topic is on myopia, and I would be focusing mainly on the how to optimize the refractive outcomes and visual outcomes in cases, and we'll leave the other for a different discussion. So one of the most important factors what we have to do in pediatric cataract surgery, and which is different from adult, is the pediatric biometry because of the poor cooperation and fixation, myopic shift related to normal eye growth and axial length elongation after pediatric cataract surgery, and the post-op amblyopia therapy. So these are some of the things that we need for pediatric biometry, which is a handheld keratometer. And unfortunately, now we get we don't get only keratometer; we get with a axial length measurement auto-refractor also, which is not of much use, along with either a contact or immersion. Because if the patient is not cooperating for optical biometer, then we will have to do it under general anesthesia in the OT. And I'll just share one small video of how we do in the OT. And what you can see here is we are not using any speculum for the child when taking the keratometry reading, because that can cause some errors. Keep the eye properly moisturized with a normal saline or balanced salt solution, after which the axial length is taken. And we keep the whole range of IOL with us, so that once we get the actual biometry reading, we don't fall short of the IOL. And then we decide on what the IOL to be implanted. So to minimize the errors, the measurement should be taken without the use of eye speculum, as we saw in the video, but to prevent corneal dryness, and BSS should be instilled frequently. After doing this, then what formula to be used? And unfortunately, in pediatric cataract, we are still not there in terms of accuracy as compared to the adult cataract. And reason being, because these are shorter length eyeballs, steeper cornea, higher K reading, and the K reading, especially in the first 2 years, changes very fast. Smaller AC depth. So error in axial length can affect IOL power calculation, which is it increases to 3.75 diopter per millimeter of error as compared to 2.5 diopter in children. Another important issue by why we have not achieved that perfection is the effective lens position, because after surgery, when we are doing a posterior capsulorhexis and anterior vitrectomy, the effective lens position also changes. So some error will be there. We don't never hit the target, but that is not the aim also, because we have to aim at a slightly hyperopic child, and we don't aim for total emmetropia. And as you can see, in children, the axial length measurement in the first 10 years, what you see here is changes from 17 millimeter to 23 millimeter in normal children. And that accounts for maybe almost 10 to 12 diopters if it doesn't correspond with keratometry changes also. Some crude methods are used for IOL power calculation, which I would say should be avoided, because just with axial length, and if we are using IOL power in present days, it may not be acceptable. And another thing is undercorrection. Again, a controversial topic here, because there are various school of thought, like in children with 1 to 2 year, what was prescribed earlier was 40 to 60% of undercorrection. But in these children, if they are not compliant with spectacles, that may induce amblyopia rather than causing any benefit to the child. So normally what we use is either SRKT or Barrett's 2. And another important issue here is the target refraction. And we generally aim for a small hyperopic correction to balance the myopic shift in the future. But there are other factors also which we have to consider, and which is smaller children, the myopic shift may be faster, and then we have to go for a slightly more hyperopia. Status of the fellow eye, especially if it is a unilateral cataract, it may lead to we may have to balance it with the refractive status of the other eye, and also with the expected compliance with spectacles. Parents' refractive error will give us an idea about the future myopic shift in the children. And if it is extremes of power, then we have to, what I do is generally I limit myself to the IOL power that is available, and especially we don't get IOL power beyond 30 diopters generally. Bilateral cataract is again early surgery. By early surgery, what we mean is earliest what we can do is at around 3 months of age. It should not be delayed beyond that because of the risk of visual deprivation. And what I prefer generally, I space both the eyes around 1 week apart, but there is it can be done maybe 2 to 3 weeks later also. Unilateral cataract, it is a bigger emergency when compared to a bilateral cataract, and the age at which the child has to be operated can be a little earlier also. Choice of IOL, definitely not hydrophilic, sorry, because long term there are chances of calcium deposits in hydrophilic lens. So in children, those have to be avoided. Mainly the current gold standard is the hydrophobic lens, and that can be either a biconvex or aspheric. But most commonly what is used is a biconvex lens, toric in older children, because then the change in refractive error is lesser. EDOFs and trifocals again are matter of discussion. There is still no consensus regarding these IOLs in children. Now, post-op refraction, what we do once the surgery is done, after surgery, post-op refraction, generally we overcorrect for intermediate vision for children, because in preschool children, their life revolves around intermediate vision. And school-going age, then we shift to bifocals as the child grows. When there is a possibility of giving a slightly larger frame, then we can go for progressives. Important topic, and that correlates more with the topic of discussion today, is the myopic shift after cataract surgery. And the factors which generally are responsible is the age of surgery. Earlier the surgery, the chances of faster myopic shift is higher. Unilateral cataracts, myopic shift is higher compared to bilateral cataract. Glaucoma, if there is a abnormal myopic shift, we have to always suspect glaucoma and check the
Doctor, 1 minute left.
Yeah. And use of low dose atropine in pseudophakic children is again can be tried. Post-op care will be amblyopia therapy, as all of us know. IOP check almost at every visit, especially in the first 1 or 2 years after surgery. Frequent follow-up. What I do is generally my first follow-up is about after glass appointment is about a month after that, and after that every 3 months, and if patching is being done, it can be even 2 months. Constant conversation with parents is very, very important, because they have to realize and they have to be a party to the treatment, because all the implementation has to be done by them. Thank you so much.
Thanks, Dr. Lau. That was a wonderful talk. What is the IOL formula you use?
I mainly use SRKT.
Any else has something different to add at this point? Swati, do you have any question to take, or shall we go on to our next speaker?
Sir has covered everything beautifully, including whether we can add atropine or not. Yes. So as all our speakers have told us, check for axial myopia. If it's a true axial myopia, I think we can start atropine, even in pseudophakics, because the mechanism, as we know, is not the accommodation. It is on the retinal receptors. Thank you.
Thank you. We go on to our next speaker. Dr. Manjula Jayakumar is a senior consultant pediatric ophthalmologist at Dr. Agarwal Eye Hospital and Research Center, and her talk is strabismus and myopia. So on to you, doctor.
So am I audible, ma'am? Yeah. My slides are seen?
Yeah.
Thank you very much for the opportunity. Today I have a very interesting topic on hand, strabismus and myopia. Okay, first let us look at some of the facts associated with strabismus and myopia. You can get every type of strabismus with myopia. It could be comitant, incomitant, horizontal, vertical, or a combination of both horizontal and vertical. Why does strabismus develop in myopes? Because of anisometropia. Myopia causes disturbances or anomalies in accommodation and convergence. With very high myopia, especially pathological myopia, you can get muzzle path deviations which causes strabismus. Okay, this is a simple classification of strabismus in myopia: concomitant, incomitant, rarer forms of myopia, which includes the progressive esotropia, which is acquired. So I'll be dealing with each of these entities in detail. First look at is comitant strabismus, myopia, and intermittent divergent squint. We know that intermittent divergent squint is a common type of strabismus, and 70% of children with IDS do have a myopic refractive error. So let us look at these slides. There is no manifestropia. When you do the cover-uncover test, you find that there is an intermittent tropia present. Let's see this video. As the cover is placed, you can see the deviation under the cover. The eye is, the fusion is broken, the eye is deviating. And when you remove the cover, the eye takes up fixation. So when you find that these children, you of course give them myopic glasses, but when you find that these children, there is a deterioration in fusion, both for distance and near, as well as there is a loss of stereopsis, you will operate on them. Until then, you can wait. So this is the same child who has been operated with an R and R in the more dissociating eye. Okay. So how do you deal with, now we have to know before dealing, let me talk about, is myopia the cause of intermittent divergent squint, or do divergent squint children develop myopia? Both is their cause as well as effect. When there is myopia, there is low accommodation demand. Therefore, there is decreased convergence, and therefore these children develop an IDS. When there is IDS, these children use increased accommodative convergence to control the squint, and therefore they develop myopia. So both are possible. So how do you treat these children? When the deviation is small, it's about 12 to 14 diopters, you can over minus. This is a child with myopia. There is a small IDS. So you can wait for surgery. You can give overcorrection, but you should not cause asthenopia. So the overcorrection can anywhere be between -1 to -4 diopters of myopic correction. Okay. The next thing is surgery. When you feel there is loss of fusion and there is loss of stereopsis, you can go for surgical therapy. And if there is a larger deviation. The next type of comitant is infantile exotropia. This is a constant type of squint, manifestropia, and it alternates, as you can see in this child. Now, in this, there is amblyopia, which is strabismic, not anisometropic. It is strabismic. Spectacles are given because there is associated myopia. You advocate early surgery. So this child has been operated even before 2 years of age. And because there are high chances of undercorrection, you need to really overcorrect these children more than what you do for IDS. The overcorrection should be in the phase of 14 prism diopters, 10 to 14 prism diopters, so that you do not get recurrences. The next is infantile esotropia. We know that esotropia, infantile esotropia is associated with hyperopia. This is the common law. But in fact, we can have less than 10% of children who have a combination of infantile ESO with myopia. So this is a child with Down syndrome and esotropia. So we have done a bilateral medial rectus recession. I had actually operated her very early and following up her for more than 5 years now. She's doing well. Next, let's go to the sensory strabismus. Sensory strabismus occurs in anisometropia. Why does it happen? There is a differential focus between the two eyes. This disrupts fusion, causes suppression of the eye with more myopia, and therefore there is a strabismus. Now, if the child is less than 5 years, there is equal predisposition to both esotropia and exotropia. More than 5 years, there is more predisposition towards the exotropia. So what are the surgical things in this kind of strabismus? You will stick to the affected eye. That's point number one. Suppose the angle is small, as in this. This man has undergone LASIK at an early age, actually a pediatric kind of LASIK. That's why he's wearing a thinner lens, but he has a small angle of exotropia. So in this, a single muzzle recession was done. Suppose you have a larger squint like this, then you can do recess and resect. Stick to the affected eye. Don't touch the other eye. Do supramaximal recession and resection to get this thing correction right. And also do overcorrection because there could be recurrences. So do a consecutive ET, which is about 10 to 14, just like infantile exotropia. Explain about recurrences to the patient. Tell that there is absence of fusion and there could be a chance of recurrence. So next is myopia and ROP. Now, as already told by Sableen, preterm infants have increased predisposition to both strabismus and myopia. What are the causes of myopia in a preterm child? Physiological or axial. It can be myopia of prematurity because of arrested anterior segment development. It can be myopia because of severe retinopathy of prematurity. So strabismus occurs in myopes, in preterms, when there is presence of ROP, when there is a refractive error, when there is anisometropia, when there is lower birth weight, when the child is associated with neurodevelopmental anomalies. So myopia in a preterm infant can also be there. Strabismus in a preterm infant can also be there. When there is myopia, you give myopic glasses. When there is strabismus, you will surgically correct them at an appropriate age. But you should also remember, look at the fundus, because there can be a pseudo-exotropia because of a macular drag and a positive angle kappa. So all the patients may not have a true strabismus. You should also keep at the back of mind that there can be a pseudo-XT. Now we are going into the world of incomitant strabismus. The most common incomitant strabismus associated with high pathological myopia is the esotropia-hypertropia complex, which is called as the myopic strabismus fixus. Now, this is because of deviation of muscle parts. You need to do a neuroimaging because you will see the shift in the muscle pulley. The superior rectus will be shifted nasally. The lateral rectus will be displaced inferiorly. You get an esotropic hypertropic complex. Look at the high myopic spectacles, and there will be limitation of abduction in both eyes. Surgical treatment, which is different from other strabismus surgery. You need to do a myopexy, which could be a suture myopexy, or it could be using a silicone band. You unite these two displaced muscle parts at the prolapsed supratemporal aspect of the globe so that you do not have a progressive increase in strabismus and strabismus fixus happening. So this is the first kind of incomitance going. The next one, equally important, is exotropia, hypertropia. People thought that this is
okay, 1 minute left.
This is a sensory exotropia, but it is not exactly a sensory exotropia. Again, there could be deviation. Now, this lady was treated with an inferior rectus recession along with Faden and plication of the medial rectus and recession of the lateral rectus. Of course, you have the progressive esotropia acquired ACE, which is of the Pilchowski type. It can occur in low and moderate myopia. So this is again treated by surgical correction. There are certain special consideration. One thing in measurement of deviation, what you measure is different from true deviation when you do it through spectacles because of the prismatic effect of the high myopic glasses. So you have an undercorrection factor. You can use either the Scattergood or the Hansen classification. Always neuroimage your patients. And what about refractive surgery in myopes with strabismus? First, you can do refractive surgery, wait for 2-3 months and do strabismus surgery. Refractive surgery, if it is an exophoria, can decompensate after the refractive surgery. If it's an XT, it is almost the same. Esotropia can lessen. Sometimes you can do the reverse, also do the strabismus surgery, but use a fornix approach when you do it and then go for refractive surgery. Of course, if you are going to do refractive surgery before strabismus, you can have a torsion on the table on supine position. It can be aggravated, so use an internal fixation target. Always there is risk of scleral perforation. So this is thin sclera, high myopia. You take posterior bites. So be careful. Do a very superficial scleral bites when you do the strabismus surgery. So myopia and strabismus go hand in hand. There is a close association. You need a tailored approach towards the strabismus. Look at each type of the strabismus which occurs with myopia and accordingly think of your post-operative correction, how it should be maintained and when you should take up these patients for surgery. Thank you very much for the opportunity.
Thank you, Dr. Manjula. That was a very passionate talk. Very nice. Swati, would you like to take a question?
Ma'am, it was wonderful. No questions. Ma'am has covered the entire panorama of squint within this small panorama talk. And the clinical photos, post-ops were beautiful to see, ma'am. Thank you.
Thank you very much, sir.
The only thing I would like to add is we must know the difference between heavy eye, knobby eye, and sobby eye. So whenever there is glaucoma, how to differentiate on CT ground, CT base, obtuse angle between superior rectus and lateral rectus. Thank you. It was wonderful talk. Thank you so much.
Thank you so much.
We go on to our next speaker, Dr. Matthew Kurian. Dr. Matthew, you're there? Who's the medical superintendent, senior consultant and head of the cataract and refractive services from Chaitanya Hospital and Research Institute based at Kochi. And he is going to be talking on surgical management of subluxated lens in myopia. So on to you, Dr. Matthew.
Thank you very much for this opportunity. So I'll be talking about the subluxated cataracts or subluxated lenses. And this can be both the crystalline lens as well as the natural lens. And what we need to know is that the etiology can be multifactorial and pediatric individual. And in high myopia, the retinitis pigmentosa is one of the situations where you can have it in the adult onset with the progressive zonulopathy. In terms of clinical evaluation, we need to be checking a few things. One is the family history, look for trauma and other visual symptoms, and also look for syndromes that may be associated with it. In terms of ophthalmic evaluation, obviously phacodonesis is the most important thing, and we need to see whether the zonules are present. And when you see this kind of a spikes over there, you can be assured that there are some zonules, but these may be stretched. When you see a very rounded lens edge, it means that there is absence of zonules. Flat would indicate that there is attachment at either end. And we need to assess whether there is additional capsular damage and whether there is any, what is the density of the nucleus itself, whether any other associated posterior synechiae, vitreous prolapse, etc. is present. Coexisting glaucoma, retina pathology is very critical, especially in a myopic situation where there could be a presence of the peripheral retinal changes, which could lead to, if missed, could lead to a retinal detachment. Supine examination is very important in these patients because we are looking to see whether there is any ACD irregularity or asymmetry which worsens when the patient is lying down. So the risks that are involved are the vitreous loss, post-dislocation, posterior dislocation, or IOL decentration, which can happen in the late stages also. And the intraoperative challenges include those of the anesthesia that we would do. The placement of the wound, rhexis needs to be centered on the bag. Hydrodissection is very critical because that is what is going to allow us to rotate a bag with rotate the lens in the bag in the situation of weak zonules. Nucleus disassembly must be perfectly executed. Choice of fluidics is critical because we don't want fluid to go posteriorly. And so viscoelastic, which will tamponade the area of the dialysis, is critical. The choice of lens and where to place it and methods of IOL stabilization are critical. The biometry concept has already been touched upon by previous speakers, so I will not go further into details on that, except to mention that we should make sure that we are getting it on the macula and not on some aspect of a posterior staphyloma, which would alter the outcome of the biometry. So in individuals with focal dialysis, we need to be able to identify this kind of a very early situation and to be able to prevent it from progressing further. Generalized zonular weakness, as in this case, is much more easy to identify because the whole bag is mobile and the folds, as we create the rhexis, is very prominent. Only thing is we need to be able to make sure that we are able to not lose the bag at this stage and are able to retain the bag throughout this procedure. So shifting to a microcapsular rhexis forceps at this stage is very good. We can use a crosswords technique when it becomes very difficult to dimple and break the anterior capsule. And here you can see that gross amount of loose zonules are present. In coloboma eyes, the area of the rexus which is near the coloboma is actually the weakest, and intraoperatively that can tend to give way. Okay, rexus runoff can be seen. Here we are just tamponading the area of the dialysis. Intumescent mature cataract in a child. 20 gauge needle is used to puncture the anterior capsule and aspirate the liquefied cortex to reduce the intralenticular pressure. And then a microcapsular rexus forceps is used to initiate the rexus. The loose capsule is phacoaspirated, and bimanually it can be removed. But then we complete the rexus only subsequently. Unfortunately, this rexus has run a little bit to the periphery. So placing a CTR, there is not enough overlap of the anterior rexus over there. And so it will tend to prolapse out. So in this case, a less than desirable outcome in that the lens was just placed in the bag. Intraoperative stabilization can be by capsular hooks or CTR, and these are of various sizes. And then this is a video to show why it is necessary. Here you can see the bag has come entirely into the port and the fragment is just floated up. Fortunately, nothing goes behind, and we are able to release the bag and create space there and complete the case without difficulty. So intraoperatively, we want to be able to do proper stabilization of the bag using hooks, and later stages we can use a CTR also. Gross dialysis noted over here. So we are creating space for the CTR, which is placed early over here because of the gross nature of the 360-degree laxity, and viscodissection creates the space, and then the lens, the CTR is guided into the crystalline lens space that is created by the visco using a microrexus forceps. And once that kind of a stabilization is achieved, the equatorial collapse is prevented, and the nucleus management steps can be executed with relatively less difficulty. So this is being speeded up in the interest of time. One thing we must remember is that we should not be having a centripetal force. We should be using tangential forces to prevent the worsening of the dialysis. Once everything is done, the lens can be placed in the bag. Sometimes in the initial stages, the laxity is not so obvious, but on placing the lens inside the bag, you can see that there is this ovalization of the rexus, and this is indicator of weak zonules, and some amount of lens bag stability can be achieved by placing a CTR late, and you can see the round rexus there. Long-term fixation options, capsule retention rings or segments. And here we want to move the segment which is pre-threaded with 90 proline now. Earlier it used to be 10 proline, but we know that it tends to give way. Under a scleral pocket, it is railroaded through, and the lens is attached, the segment is attached to the area of maximum weakness. In pediatric cataracts, we have to use microrexus forceps to be able to well control the
1 minute left.
Rexus of adequate size. Phacoaspiration is all that is required over here. And once the lens is in the bag, we are able to then dial the lens into the bag, and fixation again, instead of using the Sioni, which is a fairly bulky one, we are using a capsular tension segment, again attached under a scleral pocket in the area of maximum zonular weakness. And to achieve 360-degree stabilization, capsular tension ring is placed in addition to the CTS. So technically, surgery can be lensectomy, vitrectomy with aphakic contact lenses or spectacles, iris fixated intraocular lenses, scleral sutured. But in myopes, we have to be careful about the suturing because of the thinner sclera. Implantation of in the bag is most desirable, and femtocataracts can help in giving a good rexus in the situation of weak zonules. The nature of zonular weakness, whether it is static, in which case we can use a CTR. If it is progressive, we need to use a suture. The type of cataract, if it is a very hard cataract, we need to plan for SICS or something like that. Otherwise, in a normal cataract, we can plan for phaco. And extent of zonular weakness, if it is a very small amount of zonular weakness, no CTR is required. In higher amounts, CTR plus suture, and in extremely 180 degrees plus, maybe SFIOL or ACIOL is desirable. Finally, the complications, lens-induced glaucoma can happen. Lens can come into the anterior chamber, especially if the lens is touching the cornea. Then there can be decompensation. Lens opacity can be mature or hypermature, and there can be lens-induced uveitis. There can be inadequate visual acuity, not correctable by refraction. There can be incomplete luxation of the lens, and in myopes, retinal detachment is always a problem. Thank you very much for this opportunity.
Thank you, Dr. Matthew. That was a wonderful array of videos for every possible complication or challenge that happen. Do you have any experience of using a large optic IOL in a high myope?
Yeah. In a few aniridia cases, we have used those kind of very large optics, but it's also got a peripheral area of artificial iris to prevent photophobia. Significant challenge that I faced in pediatric subluxations was, you want to create a posterior opening in a younger child, posterior primary capsular rexus, and then for the subluxation, you need to place a CTR, and the combination of doing a CTR plus IOL in the presence of an open posterior capsule has been challenging, though we have managed it without too much of drama in the few cases that we have needed to do it.
Yes, that was a food for thought. Thank you very much, Dr. Matthew. We go on to our next speaker, Mr. Swastik, who's an optometrist who's done his BSc optometrist and worked in Manicon and is now working in V Square Medi Solutions as a South India consultant for Keracare, scleral, and ortho-K lenses. And he is going to be talking on contact lens spectrum for myopia control, applications and considerations. So on to you, Mr. Swastik. You're unmuted.
Swastik?
You have a... Yeah. You can start. Yeah. You can unmute yourself and start your talk. You're having some problem?
By the time he is fixing a problem, I just have a question for Dr. Matthew. Do you have any experience of suture degeneration when you are fixing your ring for long term?
Yes. So initially, the material of the suture was 10-0-proline. That gives way. So we switched to 9-0-proline. And I have a situation where third time lucky. Initially, CTR, bag IOL CTR complex luxated. So I did bilateral CTS in that case. Then the suture broke. And then I was able to bring the CTS out of the bag into the anterior chamber and thread Gore-Tex through it. And then finally the Gore-Tex has stayed.
So in our institute, we are using one special IOL, which is suture without suture, without glue. You can just fix the IOL. That is PMMA. Scleral tuck IOL, scleral tuck IOL, which is available in with Omni. So we have experience using in subluxated lens also.
Yeah, true. There are no perfect solutions in this. We have experimented with almost every technology and method that has been described. Yamane, glue, Shariat tunnels, more recently the CMT flex. For a long period of time, I think the suture was the preferred method, but of late I have now shifted to the CMT flex.
Mr. Swastika, you're not able to connect?
Audible now, ma'am?
Yes.
You're audible, but your presentation is not seen.
Yeah, I'm doing it now. So screen is visible, ma'am?
Yeah.
Yes. Audible and visible.
Shall I go ahead?
Yes, go ahead.
Thanks a lot. Thank you for the opportunity. The slight internet issue, I guess. So we deal with the specialty practices. So I'm basically from V Square, and we deal with dry eye devices, vision therapies, clear contact lenses, and lenses for keratoconus as well. So today I'm going to talk on the lenses for keratoconus. I'm going to talk on the myopia control strategies, contact lenses, and the options available in the market. So it all started from here. Dr. L. Smith, who was the patented professional designer for peripheral defocus theory. So he was the one who gave the concept of peripheral defocus, where he says the central fovea is not the reason for elongation of axial length. It is the peripheral receptor cells. So these are the signals which provide eye growth. And your central retina, when we provide glasses, your central retina is focused, your central light are focused on the retina, but your peripheral rays are always hyperopic defocused. So this is one of the main reason why there is an elongation of axial length, according to Dr. L. Smith. And what we usually do in all your contact lens practice is to convert this hyperopic defocus to myopic defocus. So what are the optical interventions available? There are plenty of optical interventions. We have soft contact lenses. We have ortho-K night wearing lenses. We have a multifocal contact lenses. And we also have glasses available. And among all these things, there is a Lorick study which says nearly 63% of axial length elongation is been reduced with ortho-K lenses. And there are a lot of studies which also says the 52 to 90% of success rate with ortho-K lenses, which is one among the highest success rate compared to all other interventions. So in ortho-K lenses, 52 to 90% is success rate. There are multifocal soft contact lenses available where it is 37 to 47%. There are soft ortho-K lenses, which is not a multifocal design. The success rate is nearly 60 to 94%. And the Atom 2 study says that the ortho-K lenses give the best results for myopia control, and the combination of ortho-K with atropine also gives a better result. So there was also a recent study which says that the low dose atropine may not be the ideal intervention for slowing down the progression of myopia. The other different options for for contact lenses in controlling myopia is the traditional multifocal lenses. So these are the regular multifocal lens what we usually give for presbyopic patients. So we give a center distance design where it is on relieving near accommodation. So it may not be so useful in this case. The second option is the peripheral inward focusing lenses, which are the ortho K lenses for myopia control, where your peripheral defocus is from hypermetropic, it is converted to myopic, and this is irrelevant to accommodation. So, and the next option is something based on PVS, preferential visual span, we call, and these are soft ortho K lenses without a multifocal design. So this works on the M signal pathway. So these are the ortho K lens design where it is basically based on the corneal molding. So if you see the first picture, this is the pre-ortho K lens corneal topography, and this is the post-ortho K lens corneal topography where your central epithelial cells are migrated to the mid-peripheral region. So your mid-peripheral region is being steepened, and this is the bullseye pattern what we usually call when we do the lens fitting. So these are the ortho K lens with night wear, where we sleep with the lenses. Next day morning, your cornea is flat in the center, which helps in giving a good vision, and the peripheral mid-peripheral region that is steepened, which helps in controlling myopia. So there are different ortho K lenses which helps in myopia control. The regular ortho K lens, which is flat in the center, steep in the mid-peripheral region, which has a success rate of nearly 50% because there is something called as a concept of inward focusing. So if you see, this is the topography. The mean K of this cornea is nearly 42.5 diopters, and we fitted this with ortho K lenses, a regular ortho K design. The ratio is 1.5, which means the ratio between the flat and the steepest area. So here the steepest area is 47 and the flat area is 39.75. So when we calculate the ratio with respect to the average K, it is 1.5, where there are advanced lenses now in the market. So there's something called as GOV, Global Ortho K Vision, where the inward focus is much better compared to any other ortho K designs. So the success rate of these ortho K lenses are nearly 80 to 90% because the inward focusing ability is much better. So your central cells are also migrated towards the mid-peripheral region, and in this ortho K design, this GOV design, where your peripheral cells are also migrated towards the mid-peripheral region. So here the ratio, if you see, the ratio is 2.3, which is a better highest than 1.5. So this has an inward focusing ability more than your regular ortho K lens. So the reason it gives a much better success rate compared to any other ortho K designs. And the other best part is that if you see, the targeted power is -7, where the regular ortho K designs can only correct up to 4 to 5 diopters of myopia. And it is the same for lower myopic cases. It works much better, where if you see, the inward focusing is 3.6. So the better the inward focusing, your myopia slowing down progress, the myopia results are much better. So this was the study which Dr. Tung, who was the patent designer of GOV lenses, he made a study on 102 cases, which is on 204 eyes, where he concluded that there was nearly 1 diopter of change every year before ortho K lens, and post ortho K, where there was only 0.1 diopter of difference. So ortho K almost 87% slowing down progression of myopia with GOV ortho K lenses. So these are the most advanced lens with better ortho K, better inward focusing ability, which also can be corrected for higher myopic as well as astigmatic corrections. So this is about the reverse curves, what we talk about. This is of -4 diopter, where your central cells are migrated towards the mid-peripheral region and the peripheral cells also migrated. And this is about the -8 diopter cornea, where it can also correct up to 8 diopters because your inward focusing ability is better. These ortho K lenses can also correct toric corneas. There are different designs called dual geometry lenses, tilt geometry lenses, E lenses, which takes up the eccentricity values. All these cases can also be addressed with these advanced technology lenses. We also have something called a soft ortho K lens, which just mimics like your RGP lens, night wearing lenses, but it is a day wear lens. It is a soft lens without multifocal region, without a multifocal power, without a near addition power, but it just mimics like your RGP characteristics, just like your center cornea is flat and your mid peripheral region is steep, because we fill a liquid inside the lens and then we place them in the eye, just like your scleral lenses. So to go in deep, this is how the lens design will be. The lens design is like this, where the lens has a mold and this mold carries the saline. So when you wear them, we have to fill a liquid saline and then we put them in the eye, and that saline remains throughout until we remove the lens. So when we take the picture of your cornea, when we take the picture of fluorescein with lens on, your center is flat where your center is correcting for your distance, but your mid peripheral region there is saline accumulated, and this saline will take up the peripheral defocus concept, and which helps in slowing down the myopia. And these lenses can also be corrected without a toric design for
1
nearly 1
minute
to 2
left.
diopters of astigmatism. And this is because of the planned flexure design we call, because of the tear lens beneath. So this just mimics like your RGP lens, and the tear reservoir will improve the lens comfort and wetting agent, just like your scleral lenses. And these lenses can also be done for up to 1 to 2 diopters of astigmatism and 15 diopters of myopia. Whereas your regular ortho-K lenses, we can do up to 5 diopters, where GOV ortho-K lens can do up to 10 diopters of myopia as well as 3 diopters of astigmatism. So what are the other benefits of soft ortho-K lenses over the other lenses? There are the day comfort. It is very comfortable in the day wear. We call it as a PVS multifocal concept, where it is not a multifocal design, but it just mimics like your multifocal. It can also be prescribed for early presbyopic patients. So it can also stimulate your ortho-K transition zones, excellent centrations, bigger optic zone for better far vision, and astigmatism correction as well. And as I told, it can be corrected up to 15 diopters of myopia. There was also a meta-analysis study which was done. Based on the study, it says the soft ortho-K lens gives much better results compared to any other interventions, including your atropine or your spectacles. So your soft ortho-K lens, we call it as soft myopic retention lenses, where it gives much better results. It is as far as your night wearing ortho-K lens, and this is because of the inward focus. So if you see, there are different products available, none of them in India, but going to launch as soon as possible. But soft ortho-K is available in India, where if you see, the inward focusing, the peripheral inward focusing ability is much better with soft ortho-K compared to any other designs, and that is one of the reasons why soft ortho-K gives much better results for slowing down the progression of myopia. And considering the ortho-Ks before starting,
You have to conclude now.
before starting up. So Dr. Ramesh sir told very well about the considerations. So I'm just keeping up, and take home message is just to take on the ortho-K results, because it gives much better results compared to your atropine and glasses. And the concept is on better inward focus, a better myopia control. And GOV ortho-K lens can correct high astigmatisms and high corneal myopias as well. And soft ortho-K lens is available in the market, which is as far as your ortho-K lenses. Thanks a lot.
Thank you. Thank you. We have a very detailed talk. Swati, you want to ask any question?
Yes, just one. So if the patient is towards 18 or 19 planning for LASIK, these kind of lenses, do they cause significant amount of corneal remolding? Should we stop them well in advance? Are they going to affect our topo and LASIK?
Yes, ma'am. So we advise to stop nearly for 3 weeks for the complete cornea to remold back again. 3 weeks is the minimum time.
Okay. So that is much shorter than the older kind of ortho-K lenses, right? Where
Yes,
it would take
yes,
3
yes.
months or 6 months.
Yes,
Okay.
yes.
Thank you.
Thank you. We do go on to the last segment, and I know you have been patient for a very long time. We have Dr. Fijio Kuriakos, who's a consultant pediatric ophthalmology at our Eye Foundation, Kochi, and Dr. Shamika, who's a consultant cataract pediatric and neuro-ophthalmology from the Eye Foundation, Tirupur. So Dr. Fijio is going to say that refractive surgery in selected pediatric patients has a role in visual rehabilitation, and Dr. Shamika is going to say that it has no role in visual rehabilitation. So on to you, Dr. Fijo. I will take your thoughts on this, Shreya, at the end of it.
Good evening, madam. Are my slides visible?
Yes.
So, good evening, everyone, and thank you, Chitra madam, for giving me this opportunity here to talk about refractive surgery for children and its role in visual rehabilitation. So, its major role is in amblyopia due to high refractive errors. So, I advise parents to make their child wear glasses and wear a patch. And it sounds simple, and it should be most of the time. But sometimes you have a patient like this one. Coming to another case report from Dr. Evelyn A. Pacey, and this child, she was a former premature and who had a history of ROP, and laser was done in both eyes, and it resolved well. But 22 months later, this is the refractive error. So her vision is poor with glasses, but she never wore her glasses at all. And they did PRK on her at 24 months of age, and this is the laser dose. And 6 months post-op, she is now more compliant with patching, and fast forward 6 years, this is the result. Severe anisometropia causes spectacle-induced anisoconia. It causes discomfort and makes them feel off balance. Along with anisoconia, anisoconvergence can also occur and impede their stereopsis and binocular vision. So children with severe bilateral high ametropia, why do they not wear glasses? Well, it's because of their neurobehavioral disorders that can cause severe tactile aversion, anxiety, autistic behavior, and ADHD. It gets worse with anything touching their face. They just refuse to wear them despite being blind without them. Next, these are those children who have poor glasses fittings, such as children with Down syndrome or other craniofacial abnormalities and microtia, which makes it difficult to wear glasses. And then children with cerebral palsy or other reason for neck weaknesses, and their glasses just ride down lower, rendering it useless. So they did a study and followed these children for 3 years and evaluated the corneal refractive and visual outcomes. They found out the corneas healed slightly faster than the adults, and it was very well tolerated with mild discomfort. These were the target doses versus the achieved dose of the PRK treatment. That is the line in the middle of the little blue area. You can see that they are close to within 1 to 2 diopters of desired treatment dose. The visual acuity also improved markedly in these patients, especially the bilateral patients. This is another patient of Dr. Pacey, a 4-year-old, when she was treated with PRK both eyes. She has a chromosomal translocation with severe cognitive disability, and she was wheelchair bound, extremely combative, and she always had to undergo a EUA for adequate evaluation of her retina. And you could see this very high refractive error that she had. And she was treated with PRK both eyes, and the treatment dose was 11.5 diopters. And so immediately after the surgery, she had a refractive error of minus 0.75. After 3 months, she comes in walking with a walker. She had never walked before in her life. She's smiling, she's not scared of anyone, and 16 years out, her refractive error is still stable, minus 1 in both eyes with clear corneas. So it was after this patient that they felt that they were doing much more than just improving vision in these children. They thought that they should assess the developmental improvements as well. So there was a study done to look at the developmental improvements after refractive surgery in a group of children with intellectual disabilities. And these were the tests. So they had to calculate the developmental quotient, which is a fraction or a percentage, calculated with the mental age in months divided by the biological age in months times 100. So a DQ of 100 would be normal. They found that in this group, the children at 6 months had improvements in all these areas of development, communication, daily living skills, socialization, and these were all statistically significant values. Until now, any improvement in DQ was basically unheard of in developmental pediatrics. So coming to everyone's main concern, keratoconus following PRK, even in adults, is extremely rare and has never been reported in children. This was a study on corneal stability 5+ years after pediatric keratectomy, demonstrated no topographic signs of keratoconus or corneal haze with stable refractive error. The keratometry has also been extremely stable in this group with no progressive steepening, significant improvements in both the myopic and hyperopic cohorts, and there was basically no complications. The patients had no corneal haze and there was no keratosis. So when we talk to families about this refractive surgery, it's important that you clearly identify the goals of the treatment, because the goal is not to get a 6/6 vision like in adults. We are just trying to prevent blinding levels of amblyopia, and it's important that the parents understand that. So when should pediatric refractive surgery should be considered? It should be considered in a small subset of children who are not responding to standard therapy. If a complication occurs, it will likely be many years in the future and treatments are available. If a complication occurs, the eye will be at least a seeing eye and worth the rehabilitative procedure. So I found this exciting study in which they found out that the visual acuity was significantly better in a group of children with severe myopic anisometropia and amblyopia following excimer when compared to a similar group of children treated with contact lenses. So to summarize, refractive surgery in children, it helps in their refractive error, visual acuity, communication skills, daily living activities, socialization skills, and there have been no serious complications long term. These were some of the parents treated by the patients with PRK by Dr. Pacey over the years and how much it really changed their families' lives. So one parent said, "You have given us such a gift. Our child who used to sit in the corner rocking back and forth now positively interacts with the family." And lastly, this one I think is the most poignant for all of us physicians and surgeons. Thank you for trying to help our child when no one else thought it was worth it because he had so many disabilities. They thought he really did not need to see very much. And that's just really like important for us to all realize that we should be able to help these children when we can and not make the decision that it's not worth it, especially when it's something very simple that takes very little time and makes such a difference. Thank you.
Thank you. Thank you, Fijo. That was a very lovely talk. On to you, Shamika.
I'll just share my screen now. Is my full screen visible, ma'am?
Yeah.
Yes, Shamika.
I need to just...
No, Shamika. It was not the full screen.
Yes, ma'am. I will share the full screen.
Yes, now it's the full screen.
Yes, ma'am. A very good evening to all. I'm very grateful for this opportunity. And today I will be putting forth some points against refractive surgery in selective pediatric patients. As it has already been spoken, unlike adults, the aim of pediatric refractive surgery is not to attain spectacle independence, but rather to promote binocular vision by eliminating or reducing the amblyogenic refractive errors. With early surgery, while we can harness the benefit of neuroplasticity, but on the downside, we are dealing with the refractive error, which is still changing and is still stabilizing, along with poor cooperation by young children. In the previous talk, we've already seen a few specific indications of pediatric refractive surgery. Let us take a closer look at some of the concerns with these indications. Starting with anisometropic amblyopia, there is no dearth of literature about the very favorable outcomes of anisometropic amblyopia, both in terms of visual acuity and stereopsis with conventional management. Additionally, newer modalities like perceptual learning and dichoptics are further promising in this regard. There are very few comparative studies till date comparing the outcomes of conventional surgeries with conventional management with refractive surgeries. However, a review of the available level 3 evidence of refractive surgeries for anisometropic amblyopia shows that while the degree of anisometropia reduced, the improvement in amblyopia was not proportional, and the functional gains were only modest when compared to conventional management. Another concern is that, as we all know, the hyperopic anisometropia is much more amblyogenic than myopic anisometropia. However, correction of hypermetropia by refractive surgery is challenging and is much limited in its application due to various concerns like inconsistent outcomes, regression, and peripheral abrasions. Thus, a majority of the proportion of anisometropic amblyopes may not be ideal candidates for refractive surgery in its current stage of evolution. Coming to bilateral high ametropia, the pros and cons of spectacles, contact lenses, and refractive surgery need to be judiciously weighed on a case-to-case basis. In this context, one of the important indications, as Dr. Fijo already described, where refractive surgery really improves the quality of life of children, is in children with neurodevelopmental and behavioral issues. However, Poor patient cooperation to pre and post-operative evaluations, increased risk with general anesthesia, and the need for multiple general anesthesias are few practical concerns limiting the use of refractive surgery in these patients as well. Coming to accommodative esotropias, while refractive surgeries can be offered to adults with accommodative esotropia, it is still not recommended for pediatric patients. And again, most accommodative esotropes being hyperopes may not be ideal candidates for refractive surgery. Now coming to some general considerations with refractive surgery in children. Patient cooperation is a practical hindrance to the widespread use of refractive surgery in young children. While on-table biometry is routinely being done for pediatric cataract surgeries, we still need some technological advancement until we can take topography maps under general anesthesia. Also in children, it is difficult to obtain reliable topography maps preoperatively, ensure compliance to medications postoperatively, and there is a higher incidence of infections and contact lens dislodgement in the post-op period due to eye rubbing in children. Coming to some anesthesia-related concerns, apart from the general risks with anesthesia, there are problems with centration and cyclotorsion under general anesthesia. But however, since most of the modern machines are equipped with tracking systems, this can be overcome to a large extent. However, the anesthesia machine and the excimer laser cannot be considered very good friends. There may be logistical problems in bringing the anesthesia equipment in the same operating room as the excimer laser, as most setups have a separate separate refractive surgery suite. Apart from that, the excimer laser is very sensitive to temperature and humidity fluctuations in the environment, and the possibility of anesthetic gases interfering with the function of the excimer laser needs further evaluation as well. Regression is another very important concern with refractive surgery in young patients. One study of pediatric refractive surgery, PRK, in high myopia with a reasonable long-term follow-up found very high rates of regression. The rates of regression found in their study were 0.6 diopters in 1 year and were higher with higher degrees of myopia. They suggested that pediatric PRK nomograms need deliberate overcorrection to account for regression. Just like regression, we also need long-term studies to assess the risk of ectasia after pediatric surgery, and nomograms need to be adjusted accordingly. Most children do not show the subclinical signs of keratoconus at a young age, and hence it is difficult to rule out high-risk cases just like we can do in adults. The higher incidence of allergic conjunctivitis and eye rubbing further adds to this risk. Apart from this, corneal haze is found to be slightly more in children post-operatively, and they may need long-term steroids which come with their own sets of complications. Also, since the aim of refractive surgery is not spectacle independence, and we usually target emetropia at that age, most children will need some glasses, and about 1/3 of the patients will even need amblyopia therapy post-refractive surgery. Thus, it is still far from being a fairy tale ending. Also, we still lack enough long-term data till we can safely prescribe pediatric refractive surgeries to our patients. And now enumerating the... yes, sir. This is just last 2 slides. Enumerating a few concerns with various procedures. Flap-based procedures are almost abandoned in children due to flap-related complications, which could be sight-threatening. Surface ablations are the preferred modality in children and can be considered up to moderate degrees of myopia in children with normal corneal thickness. However, regression, ectasia, and corneal haze are concerns in these procedures. For larger degrees of myopia, if the anterior chamber depth is adequate, phakic IOLs are an option. And if the anterior chamber depth is shallow, then clear lens exchange is an option. Each of these comes with their own sets of risks and complications, which need to be weighed against the potential benefits. Thus, to conclude, among the entire gamut of management of refractive surgeries, refractive errors in children, refractive surgeries will continue to have only a small role to play until we can have safe pediatric nomograms from sufficient long-term safety and efficacy data. With this, I conclude my talk and invite comments from seniors and experts.
Yes, Shamika, that was a nice talk. Dr. Shreya and Dr. Bhanumati, would you like to add something?
Both spoke very well. The only thing what I would definitely go with Shamika, especially for certain cases, but I would definitely do surgery, refractive surgery in young adults for accommodative esotropia when they are stable, because there is a lot of psychological impact, and we have done a study in our institute for 1,000 mothers, psychological impact on mother of amblyopic child. It was a impact on mother of amblyopic child. So that it's not only child is getting impact psychological impact, but mother also gets. So I agree with Dr. Figo in that developmental children, I'll definitely go for refractive surgery when it improves the development of the child.
Dr. Bhanumati?
Yeah, I see. I definitely both have plus and minus, definitely, both their talks. Since we deal with children with autism, sometimes they're so violent. With high refractive error, add to that. Or when we put them on these therapies, they don't wear those glasses. So to improve their concentration, we put them on many of these therapies on BTS. These children don't see properly. They're quite violent. If they tend to see better, most probably they might accept it. So which is when you cannot put them on contact lens. High refractive error with glasses, at least if you reduce it to some extent, and if they are able to see better, it might help. So especially in developmental delays, children with autism spectrum disorder, it might help. But that's what, no safety factors, GA. So you have to finish everything in one go. Do the topo.
No,
because getting a refractive error, children are so violent. I've seen this last week, a child of 10 years.
Yes.
So those children definitely might. This is something new I feel when I might start considering.
We really want to know your opinion, Dr. Chitra ma'am.
See, I have been doing refractive surgeries for the last 26 years. And in my earlier years, I have done for extreme situations of anisometropic amblyopia and followed them up with occlusion with a fair amount of visual gains for these children. The youngest I have done is a 6-year-old, and I've done more in 11, 12, 9 and 8 and all. But it's still a small number, and somewhere along the line, more understanding of corneal biomechanics and hysteresis we stopped doing. So I really don't understand what happens to those children, because earlier we were handling more specialties. Now pediatric ophthalmology is a separate segment, and they don't send any of these patients. So I think there is a massive confusion in all our minds about the safety element of treating these very elastic corneas. So that's where we stand as of now. None of those patients of ours developed ectasia though, but it's a small group.
Ma'am, would you consider ICL, considering it's reversible, we can explant the ICL? And we're not really worried about the corneal factor.
Yes, true. But not at a very young age. You can't do that at a very young age. And but yes, maybe a little young.
Older children, young teens with this autism spectrum, so that they have some amount of functional life. We are not very worried about the cornea. Probably ICL, because explanting it would just be another GA.
Yeah, I agree. But we haven't no experience on that. The pediatric.
In the case, I'll refer to you, ma'am. If someone comes to me, I'll refer to you. Then we'll know at the next meeting.
Yes. So I think all of us have to go back to our home and family and dinner. Thank you so much. Thank you so much. I know only few of you are present now, and that was probably because of running the webinar with too many topics and good topics, and started off asking too many questions in the beginning. It's our folly, but I think it has been a very gainful webinar, a variety of topics discussed. And I would really like to thank every single tier speaker and the expert panel for being with us and adding to the value of this webinar. Thank you so much. And I'm sure we will get back to you time and again. Thank you. And thank you,
ma'am,
Pati, for conducting it so well too.
Thanks a lot. Thank you so much, ma'am. Thanks for giving us opportunity. Thank you, ma'am. Good night.
Thank you, Bhanumati. Thanks, Shreya. Bye.
Thank you, ma'am.